Good morning, everyone. My name is Kira Ngozi. I'm the President and CEO of EpiLEpsy Alliance Florida, and I want to welcome you all to today's Seizure Smart Symposium. We're really glad you took your Sunday to come here and learn more about epilepsy, so thank you so much, all of you that are here. We have a few more that we know will be trickling in, but we're happy to get started with you, and we apologize for the late delay for getting started. Before we start, I want to thank our sponsors who, without them, this would not be possible. And our presenting sponsor today is UCB. They do have booths outside, so please be sure to go by and thank them for funding us to do this symposium for you. Some of our other sponsors are LivaNova, Jazz, Neurelis, Catalyst, Advent Health, SK Life, Sciences, Assertio, and Sumitomo. So let's give them a quick round of applause because without them. Besides our sponsors, we have wonderful community partners here. We have the Josh Provides, which you should definitely stop by if you do have epilepsy. They assist patients directly, and it's a great resource for you. Also, the University of South Florida is here. Epicenter's here, which has got a wonderful story if you stop by their booth. And I also want to thank some of our board members that are here. There's one walking back there, Pat Dean. She's one of our board members. And of course, Dr. Hind Kantani right here next to me. I want to make sure that you all have a great day full of information that you can take back and review. And please stop by the Epilepsy Alliance Florida booth as well. We have resources for you, and we can direct you in whatever direction you might need. We have a great lineup of speakers. We thank all the doctors and medical professionals that are here today from across the state, and I know you're going to enjoy their presentation. We ask that you hold your questions till after the program. And last but not least, I have the great pleasure of introducing a friend and a wonderful doctor who is our host today, Dr. Hind Kantani.
I shared a little speech on my notes, so I'm just going to say thank you everybody for taking your Sunday to come and join us for this beautiful and wonderful events. This is to raise awareness about epilepsy. Thank you to our organizer for making this a reality. Thank you to our sponsors for funding us and for your support. Thank you to our amazing speakers that took off again their Sunday to come and join us. And thank you for all of you who suffer from epilepsy, from taking your day to come to learn more, to teach others about your condition, to share your knowledge, to share your experience, and to have a brighter future and live a better life. So today I want to introduce our speakers, Dr. Salim Ben-Badis. He's going to be talking about not everything that shakes is epilepsy. We have not to say who is Dr. Salim Ben-Badis. He's a professor of the Comprehensive Epilepsy Center, TGH. And we have, after Dr. Ben-Badis, Dr. David Decker. He's our stroke neurologist, director of the stroke program in Advent Health Tampa, and he's going to be talking about stroke and epilepsy. Unfortunately, he cannot be joining us personally, so he will be talking virtually. And we will have also Dr. Erasmo Pizarro, who is the director of Comprehensive Epilepsy Center in Bayfront in St. Pete. And we have also Dr. Eric Vernier, who is a child epileptologist at Advent Health, and he has also his own private practice. He's going to be talking about childhood epilepsy. And another great expert in pediatric epilepsy, Pat Dean from Nicholas Children's Hospital in Miami, and her topic is preparing for the future. Thank you again for coming, and our first speaker is welcome to join us, Dr. Sunny Bennett.
Thank you, Hind. Happy to be here. I am not texting. I'm making sure I don't go over 20 minutes. Because we are really fine. So I'm going to talk about the proper diagnosis because before we start treating epilepsy, it's critical to have the right diagnosis, right? And the statistics is that at an epilepsy center, when a patient comes with difficult seizures, about a third of them turn out to not have epilepsy. So this is an important topic. One of my favorites. Before I do that, I want to acknowledge my team right here, and especially Marina, who is our research coordinator in chief and just published her first research paper. So you have to give her a round of applause, and she hates me. That was it, right? That's not painful. Okay, so I like to start with a quiz. What do you think is the most important tool for us to make a diagnosis of epilepsy? Put some choices here. Who votes for EEG? Good. Who votes for CT? That's also good. Who votes for MRI? Okay. So the EEG is the closest answer, but it's still not the right answer. The right answer is the history. Is talking to the patients and the caregivers about the description of the events. And even better than the history is a cell phone video, which is a new addition to our tools to make a diagnosis. It's almost the same as a history, except that instead of relying on an observer who is most likely a little bit panicking and most of the time not a healthcare professional, it's better to have an objective view of the seizure. So we are big fans of cell phone videos. It helps your doctor, and I encourage patients and families, if they can, to take videos of the seizures. It's amazing how much it helps us rather than hearing the description with words. And of course, I'm going to show you a ton of videos in the next few minutes. There are a couple of papers that prove this. It's not just my opinion. This is a study done by my friend Bill Tatum at Mayo Clinic, and this is our paper, which of course is better because it's our paper. But this is really an incredible tool, which is relatively new. And so again, it's better than a wordy description. And I will show you how videos are so helpful. So back to the basics. What is a seizure? A seizure is neurologic symptoms caused by an abnormal electrical discharge in the brain. Seizures can be provoked by a severe insult to the brain, trauma, hemorrhage, infection, drugs, illicit drugs especially. And that's not necessarily epilepsy. Another example of this is febrile seizures in babies, and those are not technically epilepsy, they're provoked seizures. And then epilepsy is not a single disease, it's a group of diseases characterized by recurrent seizures. And there are many different types of epilepsy. Some are benign, some are impossible to control. So it's a big heterogeneous group of conditions, from the most benign to the most malignant. EEG is very important, but especially and better than EEG is EEG video, where we can put together the brainwave and the videos of the episodes in question. Epilepsy is 1% of the population. That is a huge number of people, and about a third of them are difficult to control with medication. For us epilepsy specialists, EEG video is like a skin biopsy for a dermatologist. It's a piece of the epilepsy on EEG and video, and it tells us everything we want to know about this patient's seizure. So usually EEG video will help us to determine if the patient has focal seizures or generalized seizures, and if they are focal, where they are coming from, which can be very important. When patients with epilepsy have a seizure and they call our office, we have questions that we ask our staff to clarify. And instead of getting to fancy terms of seizure classification, I always ask, was it a big one or a small one? It makes a big difference. When somebody calls and said, I had 3 seizures yesterday, it's not the same if it's a minor twitching of the pinky or a full body convulsion that is severe. So we need to know they are seizures and they are seizures, big or small. That's a simple classification. right? Is it a full body convulsion or is it a small minor seizure, unresponsiveness, and things like that? Usually with EEG video, we will successfully answer these questions. The first one, which is my topic today, is it a seizure or is it something else? Very important. If it is a seizure, what kind is it? And if it's a focal seizure, localized seizure, where in the brain is it coming from? Those are critical questions. In this talk right now, I'm covering question number 1. Is it a seizure? So when we do EEG video, it's either a seizure or it's not. If it's a seizure, like I said, it will tell us which type of seizure. If it's not a seizure, there are a number of things that it can be, but in reality, most of them in an epilepsy center, epilepsy monitoring unit, more than 80 or 90% of them end up being what we call psychogenic, which means psychological, related to stress. That's by far the most common. So this is a generalized chronic convulsion. They more or less look all the same. This is what the brain does when it gets upset. And it's a stereotype sequence of events: shaking, stiffening. This would be the tonic phase, and then he's going to start doing more distant jerking. That would be the clonic phase. This is absolutely a typical so-called grand mal seizure. So in my classification, if a patient calls, this would be a big seizure, right? This is full body convulsion. The patient is out of here. We don't like those. We don't like to tolerate those. It's not good to have those several times a month. This is the typical duration. And then he will stop on his own 99% of the time. And then he will sleep for a while. He's not going to get up and go play tennis after that. It takes a while to recover. That's the post-ictal phase. This is a child with an atonic seizure. As the name says, it's abrupt loss of muscle tone. Those frequently cause injuries. Those are malignant. They're difficult to control most of the time. Most of the time, they're not by themselves. There are other types of seizures, and most of patients with this type of seizures are not neurologically normal at baseline. This is a typical absence seizure. It's often triggered by hyperventilation, as is this one. So she blows her pinwheel, and you can see the EEG change, and she is out of it for some time. Very brief, very few seconds. So you see what I mean by big or small? This is not as dangerous as having a convulsion. We want to treat them, we don't like them, but it's not the same. This would be a small seizure. This would also be a small seizure because it's a brief sporadic jerk, not a grand mal seizure. Nobody dies of this. It needs to be treated, and it's not normal. That's a myoclonic seizure. Here is a focal motor seizure where you have repetitive clonic jerking of one side. Let's say this is the whole right side, or the right arm at least. One of the challenges with these seizures is that oftentimes the EEG doesn't show anything. So this is again my point on the importance of the video. Same with this. This is a seizure, focal motor seizure of the face. This may or may not show up on an EEG, and I mean an EEG running during this. 50% of the time it won't show it. So the video is more important than the EEG. That's absolutely a seizure. And this is your typical type of seizure in an adult onset epilepsy. So those seizures have gone through multiple names. They used to be called psychomotor seizure, then they were called complex partial seizures. Where I trained, we call them automotor seizures, and now they're called focal impaired awareness seizure. All the same idea. It's a focal seizure. So it has a localized onset, and the patient is unaware. You have those repetitive movements. We call them automatism, repetitive stereotypes and purposeless. Like what he's doing with his mouth and his right hand. Has no purpose, and it's repetitive. Those are automatisms. And they're typically seen in temporal lobe seizures. Here's another example of what we would call a big one. So that is a focal seizure that then spreads and becomes a generalized convulsion. This can still be focal onset, which would mean possibly amenable to surgery if we can identify the focus accurately, and it's an area that can be safely removed without causing problems with movement, sensation, vision, memory, or language. Again, just like the other grand mal seizures I showed, very stereotyped sequence, tonic, stiffening, and then clonic jerking like this, lasts about a minute, and then he'll be post-ictal. Those are seizures. So now, like I said before, about a third of patients sent to a epilepsy center for difficult epilepsy don't have epilepsy, and the vast majority have what we call psychogenic seizures. The terms have changed for that too. You know, they used to be called pseudo seizures. Nobody likes that term. Some people don't like the term psychogenic. So some people propose functional seizures. I don't like it for multiple reasons, which I don't have time to elaborate. The term of choice now is functional seizures, and I happen to dislike the term functional and the term seizure. So I don't like either word. I think they're confusing. But the point is that these look like seizures, sound like seizures when somebody describes them to us, but they are emotional. Those are psychologically induced, stress-related, psychological. They're due to stress. And obviously, anti-seizure medications will not help them. So they usually come to an epilepsy center because the medications have not worked. Medications have not worked because they are not epileptic seizures. And there are many features that have been analyzed for this, in addition to the fact that the EEG does not show any epileptic discharges in between the events and during the events. These would be treated by a psychiatrist and a psychologist. They are good. There's good evidence now that antidepressants like SSRI medications and cognitive behavior therapy can help those. And definitely seizure medications, anti-epileptic medications will not help those. This is also relatively common, distant to psychogenic episodes. This is a lady who is having a phlebotomy in the left arm. She does not like needles, and she passes out. So this is your typical benign passing out episode. We call it syncope or fainting. Very common. Usually there is a trigger with these. In her case, it's a phlebotomy. But usually there is a trigger. Pain, emotion, something. Heat, dehydration. Doesn't last long. This is also syncope, but this is important because, as you can see, they shake, they jerk. They're not just limp. So we call that convulsive syncope, and you can easily see why that can be mistaken for a seizure. Patient passes out and shakes. Now, it doesn't look like a grand mal seizure I showed you earlier, but by history, if you are told the patient falls to the ground, loses consciousness, and the whole body shakes, it sure sounds like a seizure. So you can see how it can be mistaken for. These are tics. These are benign movements, most of the time on the face or trunk. They usually occur in children. They're usually benign, and they oftentimes grow out of them. The key here is that they are not unnatural looking movements or repetitive, and the kid is aware of it, and he can stop it if you ask him to, but not for very long. Then they have a pressure to do it, and then they feel better when they do it. So that's a tic. This is a sleep disorder called REM behavior disorder, which affects older men most of the time, is a precursor to Parkinson's disease, often. And he has episodes at night in REM sleep, that's why it's called REM behavior disorder, where they act out their dreams. So he's screaming, fighting, and if you wake him up at that time, he can tell you his dream. I was chasing this, I was being attacked, but it can look like a seizure since it occurs during sleep. This is a recent video of a home episode in a woman that we evaluated for epilepsy because she has these episodes of passing out. I had more video than one. And that is a concerning episode. It is not a seizure. We thought it might have been psychological, but we did an ambulatory EEG, and she has basically bradycardia with asystole, so her heart basically pauses. And that's a syncope due to that. So you have to keep an open mind. Not everything that shakes or falls is a seizure. This is not very frequent, but it would be bad to miss this. And since then, she received a pacemaker. This is a cell phone video. When they call and said the patient had another seizure, if we have the luxury of being able to look at this, this is absolutely 100% a generalized tonic-clonic seizure. No need for EEG to confirm that. By contrast, this is not no need for EEG to confirm that. This is also a cell phone video, and you can see that it behaves completely differently. That is not a seizure. But again, when they call and you ask what happened, well, she fell to the ground and she was shaking for 2 minutes. How are you going to know the difference? By history, it's very difficult. That's why those videos are so valuable. Here's another one. This is a lady that was in our epilepsy monitoring unit for several days, and we did not get an answer because we recorded nothing. And then later on, they were able to capture a cell phone video from another hospital, and that is absolutely a psychological seizure. That is not an epileptic seizure. Sometimes the free cell phone video is better than the $10,000 5 days of inpatient EEG video. This is a little subtle. Hopefully you can see the little twitching of the forearm. There's a good example of everything that shakes is not seizure, that is not a seizure. Those are called fasciculations. And it's not from the brain, really. It's from the peripheral nervous system, if you will. These are fasciculations. They're real. They are organic, but that's not a seizure. There are a few sleep disorders where we compare insomnias like this one that can mimic seizures. This is a child in sleep who's having repetitive movements for good reasons. We call this head banging, and it's a specific type of a larger group that we compare insomnias. This happens in stage 3 sleep or N3 sleep, slow wave sleep, and it's easy to diagnose with EEG video. But this one would need EEG because on video alone, this could conceivably be a seizure. You know what this is? This is an annoying person on a plane. He's a little nervous. 2 of them actually, but it's not a seizure either. I don't know what it is, but it's really annoying when you're sitting next to that person. It is a sign of anxiety, I think. And of course, when you tell them to stop, I didn't. But that is controllable. It's not involuntary. And yes, it has a name. It's called leg stereotypics. So I think I left a couple of minutes for questions. There are many types of seizures, but there are also many things that look like seizures and are not. And before we start treating people with seizure medication, it's important to get the right diagnosis. EEG video is for us. That's our tool. That's how we can really learn about seizures if we are lucky enough to get an episode on video and the EEG during the episode. And cell phones are incredibly useful, and please use them. This is my team. Some of whom is sitting at the table here. And this is Holly, who is our coordinator and is right here. And a shout out to Holly because she won an award from the American Epilepsy Society, which is the meeting in a couple of weeks, and will be attended. Thank you very much. I am at 18 minutes and a half, so I have 1.5 minutes of questions. Any burning questions? Yes. Very good question. The question is it more typical procedures to happen at night rather than the day? Yes and no. It depends on the type of epilepsy. Some epilepsies we know, such as frontal lobe epilepsy, for example, the seizures occur much more frequently at night than during the day. And for unknown reasons, some patients with epilepsy only have seizures at night. That's not fully understood why. But at least for some type, like frontal lobe seizures, they do tend to be much more frequent in sleep than in the day. Good question. One more burning question.
Yes. When are they called epileptic attacks?
Same thing, epileptic attacks or epileptic seizures, same thing to me.
Because I learned here in a meeting at the place where there's an epileptic center that they said they're called attacks when they last for 3 minutes.
No, I've The difference in attacks versus seizure depending on duration, I have not heard that. Yes, Pat?
I just, obviously the home videos are great, but do you treat, if someone brought in a home video, would you treat them as seizures before you did an EEG?
Good question. The question is whether we would treat the patients, or let's say modify the treatment based on the cell phone video alone without getting an EEG. I say absolutely yes. When they are definitive, some cell phone video is not a perfect thing. Sometimes you cannot conclude either it's bad quality or it's not enough of an episode. But when they are definitive, and many of them are, yes, we absolutely change the treatment. And I can tell you, for example, we've had patients in the clinical trial where they report grand mal seizures, and we finally get a video. Much to our surprise, it turns out to be a psychogenic event, which of course changes everything. So frequently, to answer your question, it does change management. And because it's a new tool, we're still struggling on how to document this, in the records, but now we can put brief cell phone or brief videos in the medical records. And so it becomes part of the record, and absolutely, it's a tool. I like to say it's an extension of the history, really. It's an extension of the history, so you document the same way, and you absolutely can make changes based on that. Think about it, we make changes based on history, and that's even less reliable than second video, so yes. Okay, I don't want to go over time. One more, I promise, I promise it's the last one.
What are the most common triggers when the seizures occur in the first hours of the morning?
Well, those are two separate questions. What are the triggers when a seizure occurs? In some types of epilepsies, primary generalized epilepsy or idiopathic generalized epilepsy, juvenile myoclonic epilepsy, first thing in the morning is a very common time. Again, I don't think we understand that fully, but it is a fact. For example, patients with juvenile myoclonic epilepsy, first thing in the morning is when they have their myoclonic jerks, maybe that go into a generalized tonic-clonic convulsion. Triggers is a different question, and I'll answer that. When a patient with epilepsy calls because they had a breakthrough seizure, in addition to asking, was it big or small? That's the first question. The second question is triggers. Triggers in patients with epilepsy are skipping meds. That's by far number one. Have you skipped meds for some reason? Sleep deprivation, intercurrent illness, febrile illness, COVID, the flu, you name it, or GI distress, some sort of illness on top of the epilepsy can trigger seizures. And in some epilepsies, flashing lights. Generally, that's for the primary generalized epilepsies. Okay, I don't want to overdo my time. Thank you very much.
Recording in progress. Thank you very much, Dr. Dundas, for your very comprehensive overview of seizures and the videos. We like that very much. And the next speaker is going to be Dr. David Decker, who is our director at Advent Hatim. Unfortunately, he's not able to be present personally, but he is going to be present virtually. And Dr. Decker, it's your turn.
All right, can you guys hear me okay?
Yes, we hear you.
Okay, good. It's really kind of strange doing this without an audience, but it will prevent you from heckling me. So what we're going to talk about is what is a stroke, what is a seizure, what's the relationship between stroke and epilepsy, and why these two conditions can sometimes look the same, and why it's important to make the correct diagnosis. So a stroke is a structural injury to the brain caused by either interruption of blood flow or rupture of a blood vessel. And, either of these two mechanisms can potentially put you in a situation where you develop a seizure disorder down the road. How exactly this, all the underlying mechanism of this isn't all totally understood, but what we know at least is that stroke results in some degree of permanent damage to brain structure. After that happens, recovery can occur remaining brain tissue is able to reorganize, and through neuronal plasticity, it can take on the role of that lost tissue. But one important aspect of that is that really this appears to be in addition to its original role, and that this ability to compensate is conditional on optimal conditions happening. And so when those conditions aren't optimal, then the patient can decompensate again, and those stroke symptoms may come out temporarily. In contrast, we have seizure, which is a functional disturbance due to abnormal electrical activity. And some of this you've probably already gone through, but seizures can take a wide variety of presentations. Focal onset seizures are kind of particularly important in this context, in which they involve a limited portion of the brain, and they produce a pattern of symptoms that's generally fairly restricted to, like a limited portion of the body or a limited portion of brain function. An example of this would be you have a convulsion in just one arm, or you have impairment of a temporal lobe, and language impairment. And this is in contrast to a generalized seizure, which is going to involve the entire brain and produce symptoms that affect the entire body. And so this would be your typical generalized convulsion, fall on the floor, have a seizure. When you're dealing with a generalized convulsion, usually those kind of situations are more obvious as to what you're looking at. Focal seizures can be a little more difficult to distinguish clinically from some other types of phenomena, depending on what's happening. So, how strokes lead to seizures? All of the underlying mechanism and all those details are not entirely understood, but the basic theory is that the ischemic event leads to scarring, which can then later degenerate into becoming a seizure focus. When you have a hemorrhage, that decomposing blood leaves behind a layer of iron from the hemoglobin, and that iron is an irritating chemical to the remaining cortex. And if you look at these, brain tissue post-mortem, you'll see this layer, this layer of iron that actually looks like rust on the surface of the brain, and that basically just stays there forever to some extent. And so once that happens, there is an increased risk of developing a seizure disorder down the road. So the incidence of seizure after stroke is probably more common than a lot of people think. It is one of the most common causes of developing a seizure in older adults, and about 10% of stroke patients will develop a seizure disorder at some point in their life, and typically this happens in a delayed fashion, in months or longer after the actual stroke occurs. This happens relatively less in patients with ischemic strokes, relatively more in patients that have hemorrhages. With hemorrhages, you also have a risk of seizures developing in the acute period very soon after when the hemorrhages happen. And that's actually not that big a number, but the time when you're going to see them more commonly is in a delayed fashion. So they come back to the hospital, weeks or months or even a year or more after they've had one of these events, and when they have their first seizure. So typical clinical presentations of stroke and seizure are going to be, are sometimes quite different. But, and of course, this is medicine, so there's a lot of overlap, and these are kind of broad generalizations, of course. So in stroke, you have a very acute onset of deficits, and this is generally going to be something that's nearly instantaneous in onset, and so the patient's fine 1 second, next second they're suddenly quite impaired. Seizures, on the other hand, as a generalization, there's going to be typically some more progressive nature to it. It may start out a little smaller and build up, and proceed in some phases, and then subsequent to it, the seizure actually happening, there'll be a post-ictal period, and then hopefully some recovery. So it is going to be much less of an instantaneous phenomenon overall. In a stroke, duration of symptoms is going to be most typically kind of hours. It's potentially permanent. They can happen, the symptoms can be transient and happen in a shorter period, but by and large, you're looking at a duration of symptoms that's more than just a couple of minutes. Whereas, a convulsion and a seizure, might last, a minute or two, potentially. It's going to seem like forever, but most of the time, it's going to be a fairly short period of time. The temporal pattern for stroke is typically the stroke itself is going to be a unique event. You didn't have the stroke, 5 minutes ago, now you have the stroke, and if that area of the brain tissue is irreversibly injured, it dies, and then you may recover afterwards. But that's a kind of a unique event. And whereas a seizure is going to have a pattern of recurrence over time, and then in that recurrence, they may be stereotypic events where you kind of have the same pattern of symptoms, the same clinical presentation in each of those events. Whereas, in contrast with a stroke, if you have one stroke once, you're not going to have the same stroke again. So if you have another stroke, it may be a different pattern of symptoms. And if we look at something like motor function, you're going to have typically it's going to be a loss of function or loss of movement in the setting. In the context of motor function, you have, for example, paralysis. Whereas in a seizure, you're more likely to see something like an increase in movement in the example of a convulsion. So, and of course, there's overlap between these things, and then it depends on when you're seeing that patient in terms of the loss of function, because it can, in a post-ictal period, they can appear to be paralyzed, of course. But these generalizations kind of give you a framework of, you have these things that have some degree opposite in their nature. So how can stroke and seizure look the same when we just have these various parameters which suggest that they should look look very different and be obviously different clinically. While the underlying etiology is different, they can each produce temporary dysfunction in portions of the brain, and therefore very similar symptoms, especially in the case of focal seizures. When you're having a stroke, the dysfunction is caused by an interruption of blood flow to a portion of the brain, and it produces symptoms that are dependent on the geography. It's where that problem is occurring, and so those symptoms are defined by the part of the brain that's involved. And if you have a focal seizure, and where you have an electrical dysfunction, that, and if it's restricted to a particular portion of the brain, it's going to produce symptoms of dysfunction, and they might, look very similar in the short term. Focal seizures or other seizures as well, often followed by a postictal period. In the case of focal seizure, you may have a period of paralysis in the postictal period that can mimic the pattern of weakness caused by a stroke. And when we're seeing these patients after events. So, for example, if the patient has some kind of event at home, comes to the ER, by the time they get there, the condition may have evolved somewhat. And if the patient was having, for example, if they actually did have, some kind of focal convulsion, sometimes it's not obvious to the patient. Sometimes they just may not be able to tell you what happened. They might have some memory impairment or other type of cognitive impairment. So they might not be able to tell you that clue that there was a convulsion. And then the only thing you're seeing when you're seeing this patient in this postictal period is that, well, they don't seem to be able to move one side very well, and there's a little bit of cognitive impairment. And so in these kind of settings, it can be difficult to at least immediately differentiate these things. So post-stroke seizures, it differs somewhat in at least in kind of the clinical context of how these things happen. And the important thing here is ultimately we get to, an ability to differentiate these things to avoid misdiagnosis. But, because the seizure focus is generally adjacent to where the injury occurs from the stroke, that seizure can cause decompensation and transient return of prior stroke symptoms. And so they can look very much the same, especially in the setting of the ER or the setting of, they had this event a week ago and now they come to your office and they're recounting what happened to them. And, but, an important clue is going to be that they describe this, these things as looking very similar to the way they did when they had their stroke. So they say that, looks like the stroke came back and then went away again in a short period of time. So in terms of differentiating, these two different presentations, if you see or get a history of a very sudden onset rather than any type of progressive type onset of evolution, that can help suggest more that, you're dealing with a stroke and not a seizure. If you've had a history of a stroke in the past and you've made a recovery and now you're either, the symptoms gone away or the symptom is substantially better than it was when you had the stroke, and then let's say you have a second stroke, it's not likely that it's going to produce exactly the same set of symptoms as the prior stroke. And again, it comes down to geography. So, you can't have the same stroke twice. So if that area of the brain is already damaged, it produces a set of symptoms, and then they recover, and you have another stroke. Well, kind of by definition, that means it's going to be occurring in a different area of geography, and then you're going to have a different set of symptoms like that. Of course, there's overlap, and sometimes it can be hard to tell, but if this looks kind of exactly like what happened with the prior one, then it's less likely that it's going to be a recurrent stroke. If we have a history of somebody presenting with recurrent events that are stereotypical and transient, that's much more likely to be a seizure or some other phenomenon than a stroke. I mean, yes, there is, transient ischemic attacks, they can happen. But, they don't, and again, like a transient ischemic attack would be an unlikely explanation for somebody that had a prior stroke and then develops the same symptoms again. Also, transient ischemic attacks don't tend to be high in number. So, if somebody has one of these, they might have kind of one event that's like a warning shot, and then they have the stroke. Having a large number of events prior, without any evidence of damage, and prior to having a stroke is a very uncommon scenario. So if somebody's had this stereotypic event where they get this transient dysfunction and they've had it 5 times, much more likely that's a non-stroke etiology, much more likely to be a seizure or some other type of phenomenon. So why does any of this matter? Well, it's important to make the correct diagnosis because, if you have somebody with focal onset seizure disorder, if you leave that untreated, it's going to tend to escalate and eventually get worse and lead to much more dangerous events. That the period of time over which that occurs varies quite widely from patient to patient, situation to situation, but eventually, if these things just keep happening and we don't do anything about it, then typically it leads to a worse situation. On the other hand, if you have an event that gets or a seizure that gets misdiagnosed as a stroke, then that often leads to escalating the stroke preventive measures. And so, if the patient's on aspirin and they have some event, then somebody sticks them on dual antiplatelet therapy. If that doesn't, then they have another one, then they get put on an anticoagulant. And as you, continue to pile these things on in the attempt to, prevent them from having a stroke, that can expose patients to unnecessary risk because all those measures carry some degree of risk associated with them. And, if a minor stroke or transient ischemic attack gets misdiagnosed as a seizure, then we've lost the opportunity to implement preventive measures to potentially prevent a devastating injury. And so making the correct diagnosis can be really important in this context here. And that's all I got.
Thank you, Dr. Decker. Does anybody have questions for Dr. Decker before we move on? No, okay. Thank you, Dr. Decker.
Thank you, Dr. Decker, for your presentation, and we are happy to introduce our next speaker, Dr. Erasmo Pizarro, who is the Director of Comprehensive Epilepsy Center at the Bayfront Health, and his topic is going to be advanced neuroimaging in drug-resistant epilepsy.
Give us 1 second.
You'll advance the slides for me.
Or you can just advance it for me. Yeah. Yeah, this just advance it for me. Yep.
It's the one on top of this too, the one that says brief. Make sure it's the one that says brief.
Let me double check. Yep.
Close this one out.
Close that one out, I said. This one says brief. This one says brief.
Okay. Okay. All right, I'm going to talk about neuroimaging and our clinical correlation and why it's important. So as Dr. Benvetti said, really diagnosis is essential. If you don't have the right diagnosis, then you can't really do the right treatment, whether treatment's medications or psychological therapy, or whether one is considering possible epilepsy surgery. So diagnosis is essential, and we get that through clinical history, speaking to you about the symptoms of your seizures, and also the phone videos help as well. So we're going to talk about not just imaging, but how we correlate imaging with the symptoms that we ask you when you're in the examination room to try to figure out, because more often than not, it's the patient that gives us the information through the symptoms they reveal to us, and it tells us where to look on the MRI to potentially find a cause of epilepsy. The epileptic aura is essential for finding where the network of focal seizures begins. And seizure symptoms, which we call semiology or policy, and then how they elaborate helps to tell us about the network of epilepsy so we can figure out where your seizures come from. And then we'll talk about different imaging modalities. And what's also important, the reason why this is important, because if you have drug-resistant epilepsy, if we can find an abnormality on your MRI, the chance of becoming seizure-free is 50 to 80% versus less than 20%. So that's the first critical step. I mean, of course, the first step is clinical history and classifying epilepsy appropriately. The next critical step is the MRI and, of course, video EEG. So I'm just going to briefly touch upon this. So an epileptic seizure, anybody can have an epileptic seizure. If you live to age 80, 10% of people will have a single seizure, not epilepsy, but a single epileptic seizure. Our brain has 150 billion nerve cells that makes you uniquely human in terms of language, memory, thoughts, thinking about the future, remembering the past. And all these nerve cells are kind of connected to each other. So if a group of those nerve cells misbehave, they produce the behaviors of seizures. And as you get fine balance between those neurons, some excite, some inhibit, and they create the behavior that allows us to talk and think, but sometimes they produce epileptic seizures. Next slide. All right, this is just a slide showing how the neurons are all connected such that if a few misbehave, a seizure can begin in one area of the brain and it'll activate a widespread network. So it's not just in a focal region, it'll activate an entire network. And here's just an example how one area of the brain might activate an entire network, even though it might be in the back part of the brain, it might actually move to the front temporal frontal lobe. And so when we look at the brain is rather complex. If you spread it out, it's actually takes a lot of surface area. So the crests that you can see here, and the valleys are sulci, okay? And through, at least over the last 150 years, a lot of data about mapping the brain. So when you tell me about your symptoms, I'm thinking about, I'm almost sitting in the sulcus there, or sulci, and saying, this is where it's coming from, maybe. Maybe where's it spreading to? So already thinking of a hypothesis. And then this is just an example schematic of the gyrus and then the sulcus. Now the thing is, the tricky thing is sometimes you have neurons sitting down here. Right? We can, only with really good imaging can we really find the cause. And then that area can be connected to other areas of the brain and potentially fool us in terms of localizing where your seizures come from. Now, one important thing, just to stop for a moment, is typically we ask the patient, what's your aura? What do you feel when the seizure first begins? What are the initial symptoms? And sometimes the phone videos can help as well. And that initial symptom can really point us in the right direction in terms of knowing where to look. And oftentimes, the patient tells us where their seizures are being. Now, epilepsy, on the other hand, unlike an epileptic seizure, is a condition that causes recurrent unprovoked seizures. It tells us nothing else. It just tells us a condition that causes recurrent unprovoked seizures. And there are 3.4 million people in the United States who have epilepsy, 180,000 new cases each year. 1 in 26 people will develop epilepsy in their lifetime. And epilepsy is the fourth most common neurologic condition, but 1/3 of the patients, that's roughly 1.2 million people, have seizures that are not controlled with medication. So there was a study, so I'll summarize this really quick. Two studies by the same authors, and then another one by gentleman Matson. So what happens is if you have newly diagnosed epilepsy and we try the first medication, the chance of that first medication working is about 47%. Working means you're seizure-free for 12 months. Okay. If you fail that first medication, the chance of another seizure medication working, the second seizure medication is 14%. That's 61%. Once you have failed 2 medications, the chance of further seizure medications making you seizure-free is 5%. Typically, at that point, one would do video monitoring. Maybe the diagnosis is not correct. Maybe it's not epilepsy, it's not Dementia, something else, or maybe it's a combination of things. Or someone it does in fact have drug abuse at that point. All right, so one of the founders of neurology is John Newlands Jackson, and he did studies in there's no MRI back then. He had to use his brain to figure this all out. And so he noticed that, for example, a patient who had focal symptoms of numbness in their arm and chronic jerking. And so then, based on that, knowing anatomy, he they actually did one of the first epilepsy surgeries in 1886 with the neurosurgeon Victor Horsley, and they knew they could localize that was in the motor area. Or another patient had a sensation of deja vu and dreamy state, and they found a tumor in the temporal lobe. And so this is a quote from Newlands Jackson. I remark by way of recapitulation, in other words, repeating, that he neglects the dreamy state because it is indefinite and merely curious, and such symptoms as chewing, movements, and apparent alterations in the size of this external objects. So I'll illustrate that. Because they seem like they're small things, may not even surmise that the patient has serious disease epilepsy. In the rudimentary form, until severe fit comes to tell them so. That's a convulsion. In fact, many people with subtle seizures don't get diagnosed from 6 months to a record older 40 years. So how to recognize focal epileptic seizures. And this is important because one, it's important for diagnosis, but the other part too is that sometimes we see patients, my seizures are well controlled, they're really great. I'm not having any seizures. But they're talking about their convulsive seizures. And so how about the episodes where a person stops, pauses, smacks their lips, and stares? Well, those happen 3 times a week. I said, well, what about those? I won't count those because those are not the big ones. But if you lose awareness for 60 seconds when you're driving a car, that's a problem, right? Or if you're walking down the street and you're having a seizure, that's a problem. So just remember this. Seizures are short, lasting seconds to a minute or 2. Sudden, out of context. The same, the symptoms, sensations are larger similar each time, and they can be subtle. So let's say I'm having a seizure right now, and I have a feeling of intense fear, maybe some deja vu, okay? So, and I don't want to know that I'm having a seizure. Let's say I'm fully aware. So I can have a seizure right now, so let's just stop. And then I'll go, and you wouldn't know I had a seizure. But typically the person would say, you know, it was an intense feeling, it was overwhelming, and I had to focus and concentrate until it passed. And that's a focal aware seizure, or an aura. An aura is a seizure. So the question is, why is this important? Okay, because there are a lot of places, even level 4 epilepsy centers, that don't do this. All right, so I'm going to tell you a little story. So about 10 years ago, I was giving a lecture, and my daughter Juliana, who's now in college, I kind of put her on the spot. And I said, Juliana, there's a patient who has numbness in their calf, and which is that seizure coming from? Her face turns red. She says, Dad, I don't know. I mean, think about it, Juliana. Where do you think it's coming from? Well, if his leg feels numb, it must be part of the brain that makes his leg feel numb. I said, very good. That's the first start. I said, what's his right leg? So what part of the brain is it? And she says, well, Dad, you told me that it's the opposite side of the brain that controls the body, so it must be the left side of the brain that controls sensation in the leg. Bingo! She localized seizures. Well, guess what? This person had epilepsy surgery at a level 4 center in the Midwest. Seizures coming from here, surgery down here. No good. Talk to the patient. Imaging technology is useless unless you talk to the patient. So when we try to localize seizures, we look at the zone, where the seizures begin, and other kinds of things like spikes. But really, the imaging is core. That's the first step. And so some of these findings can be really subtle. So you have to have the right protocol. Here's an example of how abnormal brain matter in that region. So I'll go through these images. So this one here, so that gentleman who had that lesion, if we didn't find that lesion, if someone did a study trying to localize the seizures, well, those arrows are where the seizures spread. So they spread here. First of that surgery here, the more abnormalities up there. All right, so the first question is, what is the aura? What are the initial features of the seizures? Then we think about other risk factors that might give us a clue. Even in terms of looking at the MRI, maybe there's a language delay or some other thing that helps us. And then we correlate, like we were talking about before. So if sometimes the feeling of fear can come from a part of the brain called the amygdala, that looks like an almond, or deja vu is an area we call periorbital cortex near the hippocampus. Visual flashes can come from the occipital lobe. Hearing can come from an area of the brain, or hearing a noise from a part of the brain called Heschel's gyrus. Oftentimes, my neurosurgeon and I are discussing cases. So some brain structures look like food or like fish. So we'll say, well, the almond or the jelly roll, which is the hippocampus, or the whale's tail, and everybody's looking at us like, and then there are focal unaware seizures, and some seizures can look really strange, very bizarre behaviors that you wouldn't even think that they're seizures. But the rule is sudden, sustained, short, and sometimes subtle. Not even that, sometimes unusual. All right, so then the next step is we do video EEG. But even before a video EEG, you need the MRI, because you need to have a hypothesis in terms of where you're going to go. And then the MRI can also help us, because sometimes we see abnormalities in multiple regions, and we might say that person's not a candidate for surgery. Or it helps us classify the epilepsy. So maybe this is not a focal epilepsy, maybe it's a multifocal or a generalized epilepsy, or maybe the MRI is normal. Or sometimes we see multiple abnormalities, but it's only one abnormality that's causing the seizures, and so that area may be amenable to surgery. So these are just, we're going to briefly go through these imaging techniques, and we'll put into regular layman's language. So we do video monitoring. I'll go to the next slide. So there's a certain protocol that is typically done. It has for many patients. So I want to have an MRI. I had an MRI done before, or let's say, can I go to my local hospital to have an MRI done? And the answer is no, no, and no, because this is a specialized protocol that is anywhere from 2,500 to 3,000 images. Okay, high definition. So a regular MRI scan might have like 100 images. It takes 15 minutes. This takes an hour. And then these are just some examples of the high resolution images that one can obtain. So this is this is an abnormality. So typically, this is what it's supposed to look like. That's the sulcus. That's really hard to find. I mean, I'm showing it to you. That would be really hard to find. This is a woman who had seizures, and her seizures would be like this. And she was aware during the show, and then be brief. And then this is a woman who had seizures since age 4, and she would laugh. She would giggle during her seizures. And then if it progressed, she would just step up and down, and then turn prone, turn 360 degrees, and then be over. What happened to you, Catherine? I said seizure. And then she would laugh. In fact, she was in the monitoring unit having a continuous laughter seizure. And the nurse would call me. I was having patients can't stop laughing. And asked her, why are you laughing? She said, I don't know, I think it's funny. And she's having a continuous seizure that's making her laugh. But that points us in the direction to find abnormality. She had seizure surgery in October 2010 and seizure-free for 13 years. This is another kind of image that looks for blood products. This person is a physician who almost had surgery at a local frontal center in the Northeast. We're going to remove the front part of his frontal lobe. Called cavernous malformation. So even that surgery would have failed. And this is a gentleman who had surgery in April of 2002, and he had writing epilepsy. So when he would write, he would have a seizure. And then this. So this is a woman that went to multiple level 4 sectors, by 3 or 4. And so we had MRI, and she had a beautiful aura, and I tried to localize it. I think I'm really smart. It's the first mistake. And so then our surgeon says, even though I had the aura and all that, my localization was actually not correct because the aura was pointing me to where the seizures were spreading. Yeah. So my neurosurgeon first says, hey, guys, what do you think of that? My whole hypothesis just went down the toilet, but what was happening, this area was spreading to the other area, and so we did stereo EEG and localized the seizures, and she's been seizure free since May of 2018. So this is a young girl that we just monitored. So she had abnormality on both sides. She typically say, that's also good communication. Typically say, well, not a surgical candidate, but for seizures, she sees stars in the vertical row, her vision gets blurred, it stays there for a while, then it spreads, and then she gets nauseous and retches. And so we were able to determine that the seizure actually began back here, and where the lights are, and they're on the left side, and then it's there where she gets the retching. But they actually begin here, and so probably next month she'll have a laser ablation in that region so she becomes seizure free, but improve her seizures. And there's other kind of fancy techniques, computerized techniques to find abnormalities that we can't see with the eye, or we can see with the eye, but they're hard to see. So these techniques help us to point us in the right direction. And then there's scans like SPECT scan that measures blood flow, and they get an injection when they're having a seizure, and that may point us in the right direction, so then we can inject it quickly. This is the person with temporal lobe seizures on the left. Next one. This is a tricky guy. It looked like he had temporal lobe epilepsy, but his seizure began with eye blinking. And once again, we go into eye blinking status, the seizure wouldn't stop for an hour. And so it actually began in nonstop temporal lobe. And even though everything points to the right temporal lobe, that was the area that needed surgery in 2000, seizure free since. And then this is this is phone videos, as Dr. Melise was saying. First visit, they come to see me. They got to several places. And so the mom shows me a video and she frowns. And so that's a sign, there's a French term, chapeau gendarme, it's like one of those police hats. But anyway, so that indicates a certain area of the brain. I saw MRI, I couldn't really see anything. Did a SPECT and found this abnormality. I remember that night, usually going behind, unfortunately, but that was that night, did a video call with this patient from back up. And we found the abnormality as I was on the phone with her, on the video call with her. And I said, oh my God, Rebecca, this is amazing. She's saying, what's amazing? We found the cause of your epilepsy. And so then I screen shared with her, and she was able to see it herself. And then she had surgery in September of 2021, and seizure free. She was having 3 seizures a day. Again, imaging. Next slide. PET scans, our brain uses 80% of the glucose we consume. It all broke down to glucose. So areas of the brain that don't work well show reduced glucose. So this is in kind of sophisticated PET analysis that shows an abnormality in the frontal lobe. And this guy was really hard to localize, but we ended up finding a subtle abnormality on his MRI in that region, and he had surgery to be seizure free. This is not my patients from the paper. But so if you correct the PET and MRI, something like this, so normal glucose is normal, right? If it's clean, that means it's reduced glucose, and that area of the brain's not working well, and that may be the cause of why the seizures are beginning. This is one of our patients. So I saw this patient. He was originally from New Jersey. He moved down here. Successful businessman with 3 kids. And we talked about the possibility of surgery, but he had a normal MRI. So I said, well, maybe someday we'll do surgery on you. We weren't really sure what we could do. anyway, so then he comes back to me 10 years later, and he says, you know, surgery was mentioned, Dr. I want to have surgery with you. I'm saying, like, she doesn't have an MRI, I'm not sure I'm going to help you. And so I said, well, we'll do a SPECT scan. And I looked at the MRI in the office, still couldn't find anything. So they told me his symptoms, and which I maybe told me, but I did here. I get a severe pain in my head, and then he'll go like this, and that's a seizure. And so you think about areas of the brain that cause pain. What the area of this is part of the area of pain. And sure enough, this PET scan shows this. But the rest of the seizures look like it's coming from here, but it's actually coming from here. And so he had surgery in July of 2022, and I thought he had any further seizures. But this is how tricky it is. But the key thing is, it again illustrates talking to the patient. How much of that time? So then there's magnetic source imaging. It's a way of looking at the brain's electrical activity. That electrical activity has a magnetic field. So, and oftentimes people with epilepsy have spikes in between seizures, and we can map those spikes, assuming there's enough of them. So here's one example. Let me show you the next one. So this woman, she's I think 26 now. So when she was 16, she was having seizures, and she was having seizures she couldn't understand spoken language. So she says it's like, you know, like Yoda talking. So anyway, she presents with her first seizure is a continuous seizure. So it's taken to the hospital and say, your daughter's psychotic. So they send her to the psych ward, and the mother's adamant. She says, you're getting my daughter out of this hospital. She's not psychotic. There's something going on here. She was in status coming from the area that makes you comprehend language. So she had a clear abnormality on her MRI. The MEG shows this is here. And we are putting a language here, stimulated her seizures, mapped the language, and then did awake surgery in June of 2019, and she's been seizure-free since. And then we also map white matter tracts. Sometimes when you do surgery, we want to know the white matter tracts that are important for function, whether it be motor or visual function or language function, so that the surgeon can stay away from those tracts. And then Dr. Oliveira is going to talk about our new technology, ROSA, and other surgical techniques. Keep on going forward. All right, so this is the key part. So what happens is the neurosurgeon has to trust us neurologists, because we're asking the neurosurgeon, he or she, to put the electrodes in certain areas of the brain. So hopefully we've done our homework and spoke to the patient, because what happens is, now not everybody needs to have electrodes in the brain to localize seizures. Sometimes you find abnormality, you can just do surgery and you can move on. However, sometimes electrodes like that can be implanted in the brain. It actually looks bigger than it's actually smaller than that, very flexible and clumsy, but it's only 20 millimeters in diameter. So do you think, even if you put 12 of those electrodes in the brain, 20 millimeters in diameter, and they can only record a centimeter around it, you'll never find seizures. So we have to be careful not to have hubris, which is exaggerated prior self-confidence. And I'm not speaking of others, I'm talking about myself. So we have to stop for a moment. What am I doing here? Is this right? And then be open to feedback, because someone else may say, you know, Dr. Casar, I think you're wrong. And I have to say, okay, let's relook at this. Let's look at the hypothesis. Am I correct? Because ultimately we're doing a procedure on a person. We want to make sure that we're correct. So as we conclude here, this is from William Lennox. No disease is more intriguing, more protein, more pressing for a solution than epilepsy. And again, you can see this is the brain very complex looking at it, but then you see in the microscopic part of the brain that is so incredibly complicated. And we learn, when I would help people, but each patient, we learn so much about epilepsy, we learn so much about behavior. It's really just incredible. And we partner with the patients, because the patients tell us about the seizures. Sometimes we stimulate the seizure with electrodes in the brain, and we can break the seizures into components. And the patients even tell us even more stuff about their seizures while we're mapping them than they could before, because we can always produce their seizures on demand, and they'll tell me stuff. And I said, why didn't you tell me that before? He said, because it happened so fast. He said, since you've done it 5 times, I can focus on what's going on and they'll tell you better. So the key thing is that we have to, first of all, we have to have intellectual humility as doctors, including myself, be open to surprises, serendipity. You have to keep an open mind, be humble. You have to try to remove your ego from the equation as much as is humanly possible. Not fully possible, as much as humanly possible. Pay attention to detail, be obedient. Obedient means obedient. Obedient, move closer and hear. You care what the patient's telling you. And have a sense of childlike wonder, be curious. Like you don't have the answers. It's just like a kid riding a bike for the first time. This is incredible. What is going on here? And even when you're surprised by something you don't expect, just accept it and say thank you. And then work with, respect, and listen to other opinions with an open mind. And this is important because I got situations. We want everybody on our team to be able to have an input and even challenge me. One time I had this great analysis with this kid. I wasn't a kid anymore. So I'm age 6, I mean, Seizure at age 19. And so his seizure was very deceiving. At the beginning of the seizure, she's like making small emotions. So my EG tech says, I can't really think about those little, well, he wasn't lip smacking, he was making small emotions. And the earth stopped on its axis at that time. It's like, looked at it like, probably 40 of his seizures and totally missed that. But that was a great clue to his case. And my EG technologist is the one that pointed it out to me. So the other part to it is we've got all this technology, it's great. We have artificial intelligence, it's great. But the bottom line is you're dealing with a human, a unique human being who has epilepsy. And you've got to meet them in that space. I call my office, or the exam room, a sacred space. So there's one theologian, philosopher, Mark Buber, talk about the I thou versus I it. I it is, I'm looking at data, I'm looking at data points, there's the MRI, there's the PET, there's the EG, it's at arm's length. I thou is, I'm looking at you as a human being who has epilepsy, who needs help, and you're telling me information, and I'm incorporating that information. And that relationship and my compassion for you, because compassion means to suffer with, that we're going to go on a mission, not me alone, but me and my team, to try to find a cause of epilepsy. So there's artificial intelligence. I love artificial intelligence. Artificial intelligence can help us figure things out. However, it does not replace the human mind. So artificial, the definition of artificial is humanly contrived, often on a natural model, lacking in natural and spontaneous quality, not necessarily indicative of natural relationships, artful and kind of deceiving, and synonyms counterfeit, definitely only faint, hypocritical, and sincere phony. To do this, you have to be sincere, honest, and you use technology, but you have to humanize it to make it real. So as you conclude here, you can be smart, you can have wisdom, knowledge, that's all great. But the problem is if your ego's involved, you're going to try to prove yourself that you're right and you make a mistake. And I make mistakes. The worst thing about a mistake is not learn from a mistake in localization. This is a quote from Sister, my childhood matter. We should always carry all in our heart. That's a childlike curiosity, wonder to learn, with simple love, and with a little knowledge of worldly things. Holy simplicity, which means really intellectual humility, and is the way to wisdom. It shows the wise they are not fools. Because if you think you're wise, you think that you own the truth. And truth, beauty, and goodness is larger than anyone can see it. And for women, simplicity of heart, living the wisdom of the senses, much holy than supposed to the human soul. And when I think about this, I think of all my patients who've taught me so much, and start getting emotional, but I get my life. And what they've taught me, I have to tell you, I'm truly blessed. You have to do epilepsy and help these people. Because what they teach me is truly amazing. And so it's really a partnership. So thank you for your time. Yes.
You talked a lot about, can you hear me?
Yes.
You talked a lot about how the patient communicates with you. When you have a patient, I saw developmental disabilities up there, who can't communicate with you, I know it gets harder and harder. Is there a hypothesis that you go on in order to direct how you do imaging?
Okay, so someone's developmentally disabled, and let's say they can't speak or provide a history. then what we rely on is the family. And so maybe we'll ask, the family, parent, caregiver to give us information about the seizures. And again, the phone videos really help. I mean, we do monitoring, but the phone videos help because we can get a whole bunch of seizures at different points in time and to see, so the behaviors that we see initially may point us in a direction. So for example, it could be someone who's developmentally disabled, who's abnormalities on both sides, and say, I'm not sure we can do anything, but whether it be stimulation or surgery. But then what we find is that every single seizure looks the same and has the same behavior, which tells us despite abnormalities on both sides, it's only one area that's causing the problems. And that's how we do it. And it's a partnership with the family, and they, send me videos through like a Apple Cloud or Google Link, and I review those. And then when I bring them in for monitoring, then I have a hypothesis about the events to look for. Yes.
My question is, like the lady said, my child cannot speak. That sees when she's having a seizure or not. For many years, many years, I've been begging the doctors, do an MRI for Julie, do an MRI. And nobody wants to do it. Oh, MRI won't do nothing for your daughter. We do the EEG. They do the EEG, nothing shows up. She moves too much. If they have even done the 48 hours, nothing have done. So we went through all this kind of doctors, and they don't want to listen to me. I don't know why. The only doctor that has ever listened to me is Dr. Catani, and she's trying to help Julie. And even though she's beaten, she said, we're going to help her, we're going to do this. And she gives us medicine. But so far, like you're saying, so far the medicine is not working. Julie wakes up clapping, laughing, banging the headboard. She shakes, she twitches, and it's constant. It's constant. It's night and day.
So I think so thanks for sharing that about your daughter. I know how frustrating that can be, and I'm glad that you found a compassionate doctor like Dr. Catani who's listening to you. But sometimes the process takes time because it can be very difficult, particularly for a patient who maybe can't tolerate a long EEG or can't tolerate an MRI because they need sedation. But sometimes it's a process because some people come in, clearly epilepsy is only one type of event, but sometimes people have a mixture of things. Some can be behaviors, some are seizures, maybe there's more than one seizure. So what happens is it takes that relationship with your doctor over time to try to sort out what's going on, and it just takes time. But I think the most important thing is that there's one former director of the National Institute of Mental Health talked about what's most important and we saw patients with schizophrenia, but people need a person, a place, and a purpose. And so what happens is, even though your daughter's epilepsy can't be maybe figured out right now, if someone has hope and keeps on trying, they will figure it out. And having a person and a place that you trust and a goal, that's what's really key. And also that you feel like you've been listened to. And it's important to sometimes communicate that. Sometimes maybe I'm having a bad day and a patient will say, Dr. Pisano, I don't think you're listening to me. And it just stops me because maybe I've got my 20th page of the day or I haven't slept last night. And I says, I'm sorry. And they reorient me so I can kind of be focused on what I need to do.
Thank you.
All right, well, thank you very much.
Thank you, Dr. Pissarro, for your time, and thank you for this great presentation. Our next speaker is Dr. Eric Vernier from Lakeland area. He's our child epileptologist, and he is going to talk about childhood epilepsy. Dr. Vernier.
Good morning, everyone. I'm like Dr. Bimbiris, he was my training, so I have myself not to talk, but to measure myself. So This is the volcano of Izalco in El Salvador. It's one of the most beautiful volcanoes that you can ever see in your life. If you want to visit, it's beautiful. So, I'm Dr. Vernier. I'm Albany Health Epilepsy Center. So what I want to be talking today is going to be about seizure prevalency, definition, condition, pathophysiology, also etiology, age, classification, assessment, and management. I'm going to try to make it in really a smooth way for everybody to understand, everybody to know what's going on with what we do in epilepsy as well. So definition of seizure is a transient occurrence of signs and symptoms after the mental status of the patients and condition that in the brain excessive synchronous or asynchronous electricity going in the activity in total. It's important to say the mechanism that's going to happen is the polarization of the membranes could be related to sodium, potassium, calcium. Also, the sodium is in charge of the polarization, potassium is hyperpolarization. Then you can have this calcium and sodium that is going to cause you increase on spike and slow wave in the MRI. You have three chemicals in the brain, actually two chemicals. One is the GABA, which is usually protect you to have seizures, and the other is the glutamate that usually causes the seizure pattern in patients. Epilepsy is a disorder characterized for two or more seizures that happen in more than 24 hours after neonatal period. Now, refractory epilepsy usually happens when a patient is having multiple seizures and there has been tried 3 full doses of medication, and then I correct levels. Now, seizure statistics, I would like to talk to you about that. I get this for internet, everybody can Google it and will see, is one in 26 people is going to have seizures. There is 3.5 million people having epilepsy in US at this time, and under 50,000 new cases a year. Then you can see there is the formal common cause of neurologic condition in the United States, and there is a 333,000 new seizures in kids in US every single year. Like Dr. Pizarro was saying, everybody can have a seizure, but you don't qualify for epilepsy. Now, I had to talk about this because it's a taboo that nobody mentioned, and then I like to mention since the beginning to my patients. Patients usually ask you, doctor, can I die because of the seizure? Yes, you can. We have something called SUDEP. We don't know how the symptoms started, but we have more than 50,000 people dying because of epilepsy every single year. Usually happen with seizure and no control, and usually related to generalized tonic-clonic seizure. The more generalized tonic-clonic seizure you have, the highest chances that you have to have SUDEP. Now, one more time, I was talking about what the difference between seizure and epilepsy. Seizure is one single episode. Epilepsy is more than 2 episodes in more than 24 hours after neonatal period. Now, we divide it in focal and generalized. Focal is when it's coming one side of the brain, or one hemisphere of the brain, and generalized is when it happens with both brains, or when the whole brain is affected or having the spike and slow waves. Now, this is something that Dr. Vigres, I want to talk about the classification, so I want to jump in. Now, when we talk about childhood epilepsy, neonatal seizures usually are really complicated with multiple reasons. We have hypoxia, the most common one, hemorrhagic seizures as well. We have hypoglycemia, hypomagnesemia, hypocalcemia, multiple infections. You may have as well metabolism mistakes, vitamin B6 deficiency, epilepsy. You have maternal withdrawal, and this is something that I learned that I never seen in my life, which is an injection of anesthesia for the OB/GYN doctor into scalping the baby. May give you a seizure as well. Now, after neonatal period, you have multiple kind of seizures. You have febrile seizure, epilepsy syndrome, infections, metabolic causes, tumors, trauma, vascular overdose, miscellaneous like hypertension, and other kind of metabolic diseases that happen later on in life. Seizure differential diagnosis, I think Dr. Bimberis went really well defined that, but the differential diagnosis that we usually see is jitteries, tremors, breath-holding spells, and different syndrome, which is a GER, And we also have syncope episodes, you saw multiple videos. Then we have a self-stimulation behavior and psychogenic non-epileptic attacks, which is what Dr. Bingris was going with multiple videos as well. Now, one more time, what questions, when you come with a seizure to our offices, number one is you have to sit down. I mean, something that I learned with Mr. Rogers in the movie is that you have to listen to a patient. One patient is a universe, and you have to sit down, whatever you're doing, stop and listen to the patient. Ask the questions. I mean, you have to tell the patient it was the first seizure, it was the second seizure, what's having the epilepsy, how they look like, what caused it, how long was it, who saw it, tell me about any possibility aura, what did you feel, what you were doing before. You have to tell any kind of, you may think that may cause this, sleep deprivation, you went playing too much video games, everything. You have to listen to the patient, every single thing that the patient is telling you. In my case, listen to the parents because they are telling you everything about my kids. And then you see the kiddo, and the kiddo, you have to see the kiddo has failure to thrive, the kiddo has developmental delay, the person is not using all the extremities properly, so you start making your hypothesis where this is coming from. Physical examination as well is really important to us as well. You have to see blood pressure, you have to see the circumference of the kiddo, you have to see the skin to see if any kind of like a neurological disease coming from phakomatosis. We call that like neurofibromatosis type 1, type 2, Sturge-Weber syndrome. A lot of syndromes that give you affecting the skin, and it's going to be affecting you the brain, and it's going to give you partial or general epilepsy as well. Then you have to see this organomegaly liver, how the liver looks like. Then fondi, the patient has a papilledema, is increasing pressure in the brain. All this is gonna match to make you a perfect path to find the diagnosis, like your hypothesis, to have a diagnosis for epilepsy in the specific patients. Now, the initial testing, when somebody has a seizure, they usually happen, number one, family usually start running around, freaking out, they call 911, they go to the ER. When they go to the ER, what is going to happen, number one, is the kiddo is sick looking, is having fever or no fever. He's having fever, they're going to do CBC, CMP, and then possible lumbar puncture. Then you will see, if there is no infection ongoing, then CBC, CMP, then they're going to call the neurology and call that specific hospital. The plan is going to be, the kiddo is admitted or is sent home. Now, it's admitted, usually go with the EEG, and then it's going to go to an MRI. If it's sent home, then it's going to be followed by epilepsy-trained child neurologist. And then they're going to do all this testing as outpatient, like EEG, MRI, and then now we have genetic testing as well. Now, going to epilepsy syndromes, we're going to talk about benign rolandic epilepsy. We're going to talk about Wet syndrome, juvenile myoclonic epilepsy. We're going to talk about Lennox-Gastaut syndrome, and I include two more over there that is really frequent in childhood as well. So when we're talking about benign rolandic epilepsy, it's usually a seizure that happen between 3 years old. They usually last until 13 to 14 years old. This kind of patient is a partial epilepsy. It usually happen at nighttime when the people is drowsy, falling asleep, waking up. And then the patient usually happen, or if follow we call the axonial march, start in the homunculus in the mouth, then go to the eye, then go to the arm, then go to the leg, then go to the whole body. Now, the symptoms like they happen at nighttime, they just really dramatic, and then the treatment is, it happened only one time, 2 times, we don't do nothing more to give you PRN medicine. Now, it happened too frequent, then we can discuss with the family to give medication. Now, the EEG is really dramatic. It's right in the central region of the brain. You have a lot of spikes that you can see the arrows, and then that is going to give you the diagnosis. When some people is seen by non-epileptologists, they're going to try to give you medication right away because this is really dramatic EEG. But if you are talking to an epilepsy-trained doctor, he's most likely to tell you, calm down, this is not epilepsy yet. I mean, it's possible epilepsy, but we're going to give you a rescue medication, and in base of that, we take decisions. The other kind of seizure, this is the only kind of seizure that we usually treat even the EEG and not the patient. This is infantile spasm usually happen in the first year of life, but it may happen at years of age. Usually it's a sudden semi-clonic geriatric arm extension, dropping the usually patient, say the 60% secondary, 30% is cryptogenic, means that we don't know. Then the EEG is going to give you hips arrhythmia, but we have to do the whole workup. We have to do brain MRI, we have to do metabolic profile, we have to do lumbar puncture, and then after that we have to do treatment. We treat the patient right there. We start giving high-dose prednisone, ACTH, or if the patient has other pathology like tuberous sclerosis, we give vigabatrin. It's important to say that if these patients is not well treated, usually get into generalized tonic-clonic seizure, may develop some syndrome later on in life we call Lennox-Gastaut syndrome, which is going to come soon. The EEG, to be honest, guys, like what you see is what I see. I don't understand anything. It's chaotic. So you can turn it upside down and it's going to be the same thing. So nobody knows. So that is typical for with a hips arrhythmia, and that is exactly what you have to see, and you have to treat it right away. Now, juvenile myoclonic epilepsy is another kind of seizure. Usually happen between 10 years old to 24 years old. Usually happen in the morning. The patient usually tell you, listen, I usually have some myoclonic jerks when I wake up. If they have multiple myoclonic jerks, they may develop generalized tonic-clonic seizures. And if you ask and start asking, they may have absent seizures as well. So the EEG is going to be elemental, and it's going to be important to get done right away. It's going to have, you will see 3 to 3.5 polyspike and slow waves in the EEG. And then you can do genetic testing. Some books says that it's going to be, this seizure is going to start forever, but they usually get better at 40, 50 years old. They usually improve a lot. And then you do brain MRI and genetic testing as well. Then the EEG is going to show you polyspike and slow wave complexes like that. Now it's important to say the medication of this kind of seizures are really unique. It means valproic acid, lamotrigine, or also ketamine as well may be used. Lennox-Gastaut syndrome is a kind of a syndrome usually happen between 1 to 8 years old. It's a combination of multiple kind of seizures. It's going to include tonic, tonic-clonic, atonic, absent seizures as well. It's really difficult to control. The EEG is going to give you a multiple patterns in the EEG that is going to give you the diagnosis. It's important to say that one more time, you have to do EEG, you have to do MRI. Now we have genetic testing. That is the most important thing at this time. Then one more time, these patients are really difficult to control. And what we do is we combine multiple medications to try to control all the seizures the patient is having. It's important to say what is the characteristic of Lennox-Gastaut syndrome, the EEG, which is going to be pulsar spike and slow wave complexes, 2.5 hertz. It's going to be paroxysmal fast activity. That is idiopathic of Lennox-Gastaut as well. I'm going to show you the video that the EEG. And the polyspike and slow wave is background slow with the EEG as well. So you can see this in this EEG, there is something called paroxysmal fast activity followed by a spike and slow wave thereafter. Now, I would like to talk about also absent seizure. That's really common seizure that happen in this period of time. It's a generalized epilepsy, usually happen 2 to 4%. Females are more frequent than male. They have a normal IQ. What is this? Is the patient lose conscious but then lose tone? Means what is the meaning of that? The patient is talking to you and suddenly the patient nobody there. And then you do a hyperventilation test. Hyperventilation test usually trigger this kind of seizures. And then you can see even the notebook of the patients. You will see the patient is cutting words in between. And also the treatment is going to be, the most common one is ethosuximide, and it's going to be valproic acid. If the seizure was not controlled, they may develop generalized tonic-clonic seizures. One more time, you have to do EEG, which is going to give you the typical pattern, which is 3 hertz spike and slow wave complexes. This seizure could be really easy to control, but sometimes there are some cases you have to combine two medications, like Dr. Pizarro was saying, that you may have to combine 1, 2, or 3 medicines at the same time. Pinatopolis syndrome, of which the same thing is a benign occipital low epilepsy. Pinatopolis syndrome usually happen between 3 to 14 years of age. It's a seizure coming from the occipital region. The patient usually, the typical seizure is the patient becomes pale, then the patient has nausea, the patient may have a general tonic-clonic seizure and then vomit. They have hallucinations as well because it comes from the occipital region. It's a benign kind of seizures, and then we don't treat it unless they happen too frequent. One more time, EEG is going to be the key for this kind of seizure, which you can see in the occipital region, which is in the four line of all those traces. You will see spikes in this kind of cases. It's important to say now, the other kind of seizure that we have a lot in pediatrics is febrile seizures. Febrile seizures, okay, usually happen between 3 months to 5 years old. Actually, we pediatric neurologists, epileptologists, we usually say, okay, let's make it happen until 6 years of age. Now, if it happened after 6 years of age, then it's no febrile seizure. It's a seizure that the threshold was decreased by the fever, but it's not a febrile seizure anymore. Now, the febrile seizure, we divide it in two categories, simple febrile seizure, complex febrile seizure. So I put only the complex, the simple is the opposite. What does the mean of that? Complex is a focal seizure, means the simple is a generalized seizure. Complex is more than 25 minutes, so simple is less than 25 minutes. Complex is more than 1 seizure per day, simple is less than 1 seizure per day. The complex is you have more than 1 seizure the same day, or you have a status epilepticus. The simple is only 1 seizure and no status epilepticus. It's important to say that they may have recurrences, means it's going to happen more than 1 time in 1/3 of the cases, and they have more than 2, they may have 2 or 3 cases more seizures in frequency. It's important to say that a lot of families are going to ask, what is the risk to develop epilepsy later on in life? It's going to depend in multiple reasons. Number 1, how many seizures you are having. Number 2, how long the seizures are lasting. So, and then number 3 is going to be genetic testing. Now, when the patient comes with febrile seizure to the hospital, one more time, we have to rule out CNS infection. We have to control the fever, find the cause of the fever. Number 3, we give the patient rectal diastat at this time, which is a Valium to go home with the patient in case the patient has more seizures at home. And express to the family, listen, this is not epilepsy, this is a provoked seizure for fever. Now, what we do, what the recommendation we do to the families is, number 1, stay calm. Number 2, put the patient in lateral position, don't put nothing in the mouth of the patient. Number 3, we tell the patient to prevent any hurt, call 911 if you are alone or you don't know what to do. In case that you have a rescue medicine, use it. Protocol say 5 minutes. I usually tell my patients that 3 minutes or more, I would use the rescue medication right there. Rescue medication, we have multiple types, and then is another topic. Then the rescue medication can be repeated in 20 minutes after you give the first one. And the side effect or the somnolence of the rescue medicine may last between 30 minutes to 6 hours. Side effects of the rescue medication will be hypotension, sedation, or increased secretions in the patients. Now, the status epilepticus is important to mention that happening frequently in childhood as well, is when somebody has a seizure episode that lasts more than 30 minutes. Now, in pediatrics, it's a seizure that has more than 5 minutes, or a cluster seizure, meaning that you have 1 seizure, then you have another one, then you have another one, and the kiddo doesn't come back to baseline. So you say, okay, this person is going to status epilepticus, you have to treat it as a tau. So it's important to say if you go to the hospital, once you get to the hospital, then they're going to give you IV dextrose, they're going to give you normal saline, oxygen, Ativan. That failed, they're going to go back to another medication IV, which is phenytoin. They're going to go to, it failed, they're going to go to phenobarbital. They failed, it's going to maybe do Depakote. They failed, they're going to, most likely, it's going to be heavy sedation and mechanical ventilation. If thereafter, they're going to do the whole workup to find out where the seizure is coming from. They're going to do a CT, MRI, and EEG to see if the person is having more seizures. When do we start medication? Number one is when you have 2 seizures in a year, then it's a good time to start medication. Now, the only way that you can start medication is you have 1 seizure and the EEG shows clinical seizures, or when the EEG shows generalized epilepsy, you can tell, okay, it's time to start medication as well. Now, the medication usually start low, and we go up, build in blood until we get levels that we need. There is no safe medicine. That is important to say. There is not a safe medication. And then 65 to 70% you're going to be controlled with 3 medicines. It's important to say. Now, we have multiple seizure medicines in the market that we can use, and then we want to pick it up in base on what is the seizure characteristic of the patient or what is the syndrome the patient has. It's important to say all these medicines, they're going to have a different mechanism of action, and we're going to go in base on what we want to treat. We want to go with the sodium channel, with the glutamate, with blocking the glutamate, increasing the GABA, and that is going to tell us what combination that we have. I usually like to, when I go with 1 seizure medicine, I go with the most benign one, and then I go build the whole medication into everything else. Then if this fail, then we have 2 options. Number 1 is going to be ketogenic diet, and number 2 is going to be surgery. Ketogenic diet is going to be practically no carbs. It's going to be, you have to do ketone bodies in your body, you have to build in. And surgery, it could be, we have a focal lesion in the brain, we go to a specific, target that. Or if the patient has there is no specific lesion, then you can go, it's partial, you can go to VNS, or you can go also to corpus callosotomy, whatever you want to do. With the last 2 are palliative surgeries, not curative. Then the rescue medication that we give to all the families was going to be the rectal diazepam intranasal, we call valproconazepam, midazolam, and PO medication clonazepam, which is less effective, but is what the insurance like to cover because it's cheaper than everybody else. Then, what is the goal? The goal is that the patient has a normal life. So I also tell the patients, listen, I want you to have a normal life. I want you to be careful with swimming, climbing. When you walk with a really hot food in your hands, I don't want you to be burned. I want you to be warm. So please, your food has to be warm, not hot. Then I also tell the patients to tell the friends, teacher, boyfriend, girlfriends, and everybody else that they have epilepsy, because we humans, we chicken out really fast. What I'm talking about, if you're walking with somebody, that person falls next to you and start having a seizure, you run the other way around. You don't help. But if you know that person may have a seizure, you need to help. You say, okay, what did you rescue medicine? It's here, okay, let's just use it. But you have to be ready to use it. Then tell the family, listen, what caused the seizure? Can you do a diary? Can you tell us more information about it to mapping what's going on with that specific patient? And 2 things that Dr. Viveris was answering that question. It was like taking medication, sleep hygiene, and both of the above usually are the recommendation that we give to the families. When the patient goes to college, what do? They don't take the medicine and they go party. So they call you in the middle of the night and tell you, listen, my son or my daughter is having a seizure. And you ask them, listen, where are you at? What's going on? Then that's everything I had to say. Thank you very much. Just to finish, remember that I showed you the Salca volcano. El Salvador is the only country that you can be in the volcano at no time, and you can do this in 10 minutes thereafter. So it's 10 minutes, the volcano is 10 minutes from the sub-zero. So you're welcome to visit. Any questions? Yes.
You mentioned after medicine that the keto diet and surgery were options. How effective is the keto diet as opposed to surgery?
The keto diet, as per research, is between 27% chances that you will be seizure-free with keto diet, and the surgery is not that quite behind. It's going to be between 24 to 27% as well. So either one is gonna be the way to go. However, if you qualify for surgery is the way to go. Now, a keto diet is a difficult to make it happen because I always say you have no mouth and then but you like to eat pizza, cake, ice cream, keto is not gonna be the way to go. Now, if you are really well done and you have really responsible with that, it's well to try a keto diet before going into a surgery. Any other questions? Yes.
Related to efficiency and moving body transport, like in brain for people that respond to the keto diet, like your glucose metabolism.
They usually, when they have transport deficiency, I mean, they usually keto diet is one of the first things that we recommend in neonatal state because it does really decrease the seizure frequency. It doesn't make it go away though, but it does decrease it a lot.
Thank you so much.
Thank you. Well, that concludes the first half of our conference. We're moving the schedule a little bit because our lunch is being served. So we ask that you all go get your lunch and bring it back in. And we'll have what we call a working lunch. And we'll get back with our speakers. And then will all our speakers that are in the room come up? We'd like to take a picture. So I know there's a few here, so come on up for a picture. And please go help yourselves and bring your lunch back in and we'll get started as soon as you're all back. Thank you.
again, everybody. I hope you enjoyed your lunch. I don't mean to interrupt, but we have Patty ready for you. She is a great expert in epilepsy, pediatric epilepsy from Nicholas Children's Hospital in Miami, and her topic is preparing for the future. No? Well, still preparing for the future. Get epilepsy, it's good to have a plan.
Thank you, thank you, and thanks for having this, and thank you all for showing up on a Sunday, because Sunday's a rough day to get people out and coming. Anyway, so when Hind was putting together this program, and she put me on the program, and Mary and Mai came to me, and they say, we want you to talk, first of all, I guess we weren't doing this, but I always have my disclosures. So the first thing they asked me to talk about was transition, okay? And here's the deal. I've been talking about transition for years now. The Epilepsy Alliance has a HRSA grant about transition. And the problem with transition as it exists is it doesn't work well in the real world. I mean, they talk about it, and anybody who takes care of people with epilepsy knows epilepsy's a very different animal than any other chronic disease. Transition works very easily for diabetes, for asthma, for cancer, but people with epilepsy, it's all a very different disease. It affects people in many different ways. But I will tell, I don't know how many parents there are out there, but if you are a parent, you do have to think about someday your child will outgrow pediatric care. So in the planning world, you need to start thinking about like what happens, like at my hospital, we stopped seeing patients at the age of 21. Yet I transition patients at the age of 30 because some people with epilepsy chronologically or developmentally don't really correspond to the chronological age. But that some places it's 18, and in some places it's a definite. They won't see patients over the age of 18, or they won't see patients over the age of 21. Some other places are more flexible. So if you are a parent of a child with epilepsy, you have to think about that. And this is about planning. I don't think it's a good idea to wait till you hit the age. You should start looking around your community for doctors. So anyway, that's all I'm going to say about transition. But more important is transition is that those of us in pediatrics send the records to the people in adult care. But that's always a problem. So I'm going to start off by talking about seizure action plans. And it wasn't raining when Noah built the ark, right? So that's the thing about epilepsy, that you really have to have a plan before you do things. And one of the things that we have is called the seizure action plan. Now, seizure action plans exist online. There's the Epilepsy Foundation has one. There's a Seizure Action Plan Coalition. The Child Neurology Foundation has one, and the Epilepsy Alliance has one. And all a seizure action plan is something that's written down that tells you what to do in the event of a seizure. Now, in pediatrics, we use it all the time for schools because and I will tell you, I don't know when it was, like when Diastat came to the market, there's a medication called Diastat, and it's a rescue med. It's rectal diazepam that was used for if someone's having a seizure. It's a rescue medication for a seizure. And the problem, there's a lot of problems with Diastat. But when Diastat came to the market, there was a group of epilepsy nurses very involved in the American Epilepsy Society and the Epilepsy Foundation. And we were fielding a lot of calls from school nurses because Diastat was developed for people to be used by non-medical people, and mostly by families to use if their child or loved one had a seizure, so they wouldn't have to go to the ER all the time. So something to stop the seizure. So kids go to school all the time. So we wanted school nurses to give the diastat because most schools had nurses that could give it, but there was a lot of pushback. And the pushback came for a few different things. First of all, by the way it was given. To give diastat, it's given rectally, so you have to pull someone's pants down and put this up their butt. And not always an easy thing to do in a school setting. And the other thing that happens in schools is that nurses aren't always in the room when the child's having a seizure, or even sometimes in the building. So they had to train other people. And it was a lot of pushback with that. So we had to give them something. So a group of nurses, epilepsy nurses, created the concept of seizure action plans. And all it is a plan. It's just a plan. And what you can see up there, it tells you, you write in the seizure type, how long they last, how frequently the person normally has them, and the description of what they look like. And down here, they talk about rescue therapy, and I'll talk about that a little. But the truth is that we use it for schools. But there's no reason why you can't have a seizure action plan for yourself if you're a parent, if you're a person with seizures, or if you're somebody you love has a seizure and you live with them. And it's just what to do, because it's easier if you know what to do. It's like it says, Noah didn't build the ark when it was raining. It's not a time to decide what to do for a seizure when the person's having a seizure. Now, does everyone need a seizure action plan? Maybe not. Maybe if you are well controlled, maybe if you have one seizure a year. But especially if you have someone in your world that has frequent seizures, you should probably have a seizure action plan. Like what I tell, like parents, a lot of mothers know what to do. But what if you leave it with your grandparents or a sibling? So, I remember I had a girl who went away to college, and I had her hang this up in her dorm room. So if she had a seizure, the people in her world would know what to do. So if you have a babysitter or something, somebody who is not you, who knows what to do, will know what to do. And, it's really a good thing to have. Now, a lot of times seizure action plans should be written with the physician. It's really helpful. But I can tell you, these things take a really long time to write. And sometimes in a practice setting, its time is not always that available. So it's not a bad thing if you write it yourself and maybe bring it into your doctor's office and discuss it with your doctor, because it might be a time issue in the doctor's office. But if you have frequent seizures, or someone you love or care for has frequent seizures, you really should have a seizure action plan. And they come in different languages, because I know, you live in Tampa, same thing. There are a lot of people who only speak Spanish or speak a different language, and it comes in different languages. So, sometimes I give the parents in English, and I give them a blank thing so they could translate it into Spanish for the abuelos, so it's a really important thing. And again, just about this, there are 3 drugs that have been FDA approved for the acute treatment of seizures. And I think if you have seizures and you have kind of frequent seizures, you should have a rescue med. And diastat shouldn't be really given to anyone over the age of 2 years of age. I mean, it shouldn't be, all right, I'll have to go to 6, because the next drug is approved for 6 years and older. But this is really for kids, and when it first came out, and I was one of the reps that is here, worked for the company that it came out for, and they were trying to get us to have a blanket and give people a blanket so it can be given when people are at the grocery store, and which is a crazy idea, right? It's a crazy idea. So this is good for young kids. It's good for young kids. But now, if you are over the age of 6 years of age, you should never have to get diastat. Now there are 2 different drugs on the market. One is called Valtoco. It's nasal diazepam, and this was approved for kids 6 years and older. And the other drug is called Nasolam, or nasal midazolam, and that has approval for people 12 years and over. And they're both a little different. They're different. They're both benzodiazepines. They both kind of do the same things. They work a little differently. Some people respond better to diazepam. Some people respond better to midazolam. Obviously the age makes a difference. If they're under 12, you kind of have to use Valtoco. But if they're over 12, especially in teenagers, maybe sometimes you only want them to do something that they only have to do once. Because sometimes in Valtoco, there's 2 doses. And anyway, you have to work with your doctor and discuss it and discuss which one is better. But you should have, if you have frequent seizures, you should have a rescue med. And these are really easy to use. Has anybody out there used them besides you guys? Do you use it, who do you use it on? Yourself? And is it easy to use? Did you ever have to use Diastat? A lot easier, right? Yeah, so it's easy to use. You could do it with one hand. It's just a spray up the nostril. So I recommend that if you have frequent seizures or someone you love has frequent seizures, you should be using a rescue med. Okay. So, and what else? The other thing I like about seizure action plans, if you sit with people, like I like to sit with them and do it, because then you can help. First of all, it's self-management. If you can stop your seizures, you have some control. Or you can stop your child's seizures, you have some control of the situation. And you don't have to go to the ER. But it's also a chance for people to really understand their seizures and understand maybe sometimes what their triggers are, whether it's lack of sleep, whether it's missing medications, and maybe avoid having to use rescue therapy. So that's a good thing about seizure action plans, because it makes you sit down and write about your seizures and look at your seizures. So I like that about seizure action plans. So what else should you plan when you have epilepsy? Well, you should always be aware of what could happen to you if you have a seizure in that space. And I don't think people with epilepsy always think about that, or even family members of people with epilepsy. But, you should be, we should all plan. I am not a planner personally. Mary, big planner, all right? And she looks at everything that happens here and she has my big planner. And it helps to have a plan. It helps to have a plan. And so when you have epilepsy, you really need to have plans. You really need to look ahead at the situation you're about to go into. Obviously, there are things that are obvious. There's things like swimming, right? If you're going to the beach and you have epilepsy, first of all, you should never swim alone. Truth is, nobody should ever swim alone, but particularly if you have epilepsy, right? So you always have to look at where you're going. If you're on an airplane, I mean, what is going to happen to me if I'm sitting on a seat and have an airplane? I had a friend, Linda, who I met her. She was the board president of the National Epilepsy Foundation, and she had a son who had seizures. And she used to tell him, get on the plane, don't tell him you have epilepsy. As soon as the flight takes off and you're in the air and they can't stop the plane, then tell the flight attendant that you might have a seizure. You gotta be practical sometimes too. But so you need to think about it. If you're going to a building that only has stairs, just different situations. And just look at the situation. It doesn't have to be a major plan. You don't have to write it down, but just in your mind, kind of have an escape route or know what you're going to do. And it also, when you're living with epilepsy, means planning. And that means like school and work choices. Like I don't know if there are parents of young kids here that are going to school. But before you send your child to school, you should look at the school. You should go to the school and look at the building. I mean, is my child going to have to walk up a flight of stairs to get to class? You know, just kind of look at the surroundings. And if you have work, what kind of work are you gonna do? You know, when I had patients that were going to a vocational high school. So it was like one of those schools where they would go to class and then some days they would go to some place, some workplace. And they always put them in the kitchen. And I used to say to them, like, why are you putting these kids, their work situation, in the kitchen? You know, I'd go and they'd be like sous chefs or like something. Like I said, why don't they go out and work in the yard? You know, so just like you have to look at the workplace. Is it a safe environment for me? Is it a safe environment for my child? Is this a job I can do? You know, is this a job I can do? And if you are a woman, if you are a young woman with epilepsy, you have to plan your pregnancies. You know, I see a young woman there who's pregnant. I know she doesn't have epilepsy. Did you plan that? Your pregnancy? Oh, you did. Most pregnancies aren't. So here's what I tell. Like, I start my young patients, my young girls, I start them all on prenatal vitamins, even though they're not pregnant. Folic acid in particular. I start them at, you know, when they're like 12 years old. And, you know, and the reason I start them at 12 is not because I expect that they're going to go out and get pregnant, but I want them to have kind of like to be in the habit of taking this every day. So if they have an unplanned pregnancy, they at least, you know, have some protection, you know. Anyway, so, and I also tell my young girls with epilepsy, my patients, never marry anybody who doesn't have a job and doesn't treat you like a princess. That's my other advice. Even if they say they're going to get a job. And you know, if you have insurance, look at your insurance policy. You know, look at it. Read what it covers and what it doesn't cover before you sign on the dotted line. And always make sure you have enough meds. You know, this is Florida. Sometimes there are hurricanes. And, you know, there are some times where pharmacies are closed and all things like that things like that happen. So you have to make sure, you always have to make sure if you have epilepsy that you have enough meds. Okay, and then there's long-term plans. So originally the title, the second title they put in was Planning for the Future. And the truth is I work with kids. That's my milieu. I work with kids. I've been working with kids and families for over 40 years. I just look incredibly young. But, so one thing that I found out along the years talking to parents and working with parents, especially if your child has any kind of disability, you know, if there's going to be a question of whether or not they're going to be able to get a job as they get older that's going to be able to support themselves and live independently, you have to do some planning. And some of it has to be financial because it's expensive. I mean, life is expensive. But anybody with a child with disability knows how expensive, the expenses that you incur over time. You know, if you have insurance, oftentimes there's a copay for meds, there's a copay for therapy, there's copays, there's all sorts of extra expenses that add. So you kind of have to look at that and do some kind of financial planning. And I recommend to families that they set up some kind of trust for their children, if they're possible. And there are some things, there's something called the Special Needs Trust that you need an attorney to do. But it's always good if you can afford something that with an attorney, because they know how to hide money. But you can also, but there's also something called an ABLE trust that exists in Florida, that you can put money into this trust every year, and as time goes on, as long as you don't have more than $100,000 in the trust, it doesn't count against Social Security, it doesn't count against Medicaid, and you can use the money in the trust along the way for various things: school, housing, even vacations. Not your vacation if you have a child. They didn't pay for the family vacation, but it'll pay for the child's part of the vacation. So it pays for an awful lot, and it doesn't, it's not taxable income, and you can take money out along the way. It grows money, and it's a good thing. I have some patients that have some autistic features, and they're really developmentally impaired, and they don't like toys. So like what I recommend to parents are things like, when it's Christmas or their birthday, tell your relatives, don't buy them some stupid toy that they really don't want. Put the money in the account and let the account grow, so that along the way they have money for things that they need, because it'll buy wheelchairs, it'll buy communication boards, it'll buy things like that. So I just always recommend that parents look into the Able Trust, and if they're financially well off, the Special Needs Trust. And also Medicaid and Social Security. Like sometimes people don't know what that's available to them. They don't know that, when you have this, it's a disability and you qualify for some things. So you should always look into if this is something that you are owed. When I say that you are owed, that the government grants you because of your situation. And guardianship. If you're, like I said, I don't know, it seems like a lot of adults here with epilepsy, but what I talk to parents about too is guardianship. Because when your child is 18, no matter what the developmental, if he's chronologically 18 or older, it doesn't matter what the developmental age is, chronologically the government recognizes them as an adult. So it can be problematic if your child needs hospitalization. And if you had a child that had some kind of epilepsy and behavior problems, and they got into a situation where you weren't there, they could be Baker acted or taken away, and you wouldn't have access to them because you don't have guardianship. So, and the problem in Florida is guardianship isn't cheap either. So, I mean, it's easy for me to say. And then I talk about alternative living arrangements. And I'm going to say this, and parents don't like to hear this, but most of your children are going to outlive you. So you have to have some plan for the future. You have to have some plan of what's going to happen to if your child is not capable of taking care of him or herself, who's going to take care of them? And, sometimes you might have a sibling, but you might not. So I think it behooves parents to start looking at places where, group homes and things that they might be happy with, rather than wait until, it's too late and they die and their child is just put somewhere else. So I talk about that. And I also recommend that you surf the net, that you spend a lot of time surfing the net for different things. Like this group is the Epilepsy Alliance of Florida. There's also a group in town called the Epilepsy Services Foundation, and I guess the Epilepsy Foundation is also here. But there are other groups, and I didn't put it up here, but Josh Provides. They were out here today. And there are different organizations that offer help for different things. Like Josh Provides is an organization that pays for things, not medical care, but my patients who use a monitor at night, a SAMI monitor, they'll pay for that. They'll pay for the, what's the watch called? The Embrace watch. Sometimes it'll help pay for a dog. Sometimes it'll help pay for travel if you have to go somewhere and you need some money to get to some place for medical care. There's Danny Did. There's who?
Josh Provide.
I did say Josh Provides. I just said Josh Provides. Anyway, so it behooves you to look online and surf the net and to join groups like I know we have an epilepsy parent support group. I don't know how many other online groups do we have?
We have
Huh?
we also have an adult.
An adult group. So,
We have tea
I mean,
time.
if you look online and you go to support groups, you sometimes can meet people who can give you valuable information. So, that's another way of getting help. Okay, so, I don't mean to make it sound like, I mean, you have to plan things when you have epilepsy. You just have to plan things. You should all have a seizure action plan if you have frequent seizures. You should think about where you're gonna be before you have a seizure. You should think about if your child, what school he's going to and check it out before he gets there. If you have a job, look at your workplace and see how that suits you. And, you know, you just need to know what's going on and you need to look into things. And I can tell you, some of our caseworkers, they know stuff. They know stuff that I don't know. They know stuff that your doctors don't know. They know stuff like, there's a woman in our office, Roxana, who can tell you everything about Medicaid and Social Security and all that kind of stuff. And those are the kind of people that you need to make contact with. You need to find people who know this stuff because working with the government on different things is difficult. So you need to find these people. And healthcare workers need to know who to refer these people to, your patients to. I mean, we need to know who to refer our patients to. I have been lucky because I have been stuck with this organization for many years. I mean, a part of this organization for many years. So, you know, I have learned along the way some things that my colleagues didn't know, you know, so you just need to look for help. There's help out there. But the problem is that you have to really look for it. No one's going to come up to you. And my other advice to you is that if anybody offers you help, take it. And if nobody offers you help, ask for it. And the other thing about a plan should always include some fun stuff. So if you are the parent of a child with epilepsy, I recommend that you spend some time with or if you're a person with them, that you spend some time with your significant other, your partner, your boyfriend, your girlfriend, your husband, your wife, and you prioritize your relationship. Just prioritize your relationship. I have a family they have a daughter with epilepsy who's now in her late 20s. And one of the things that they used to do before they were married and had kids is like, they would go like every once in a while, they live in Fort Lauderdale, they'd go to the beach and watch the sunset. So they make sure they go once a month to the beach. And they watch the sunset and they don't talk about their kids. You know, and you need to do that. And if you have epilepsy and you're married or you have a partner, you should go somewhere sometimes and talk about things other than your epilepsy. So you should make your life not only about your epilepsy, but about your life. And if you have friends, go out with friends. I mean, there's this TV show where they talk about people over the age of 100 who live these little pieces of what's it called, 100? The blue zones? Blue zones. And they talk about places where people live long lives, they live to be over 100. And one of the things they talk about is that they have friends. They don't spend time on their phone, on texting and doing all that stuff. They hang out with their friends. So friends are important. So if you have friends, hang out with your friends sometimes. And the other thing is if you are a parent and you have children, other children, spend some time to do things with your other children, not just your child who's ill, because that's kind of what happens sometimes in families. Parents spend so much time with the child with the problem that they kind of sometimes maybe unwillingly neglect their other kids. But anyway, I just want to thank you all for coming. I don't really have anything else to say. I could go on forever, but anyway, thank you. And Epilepsy Alliance of Florida is here to help. The Epilepsy Services Foundation in Tampa is here to help. So there are people who are on your side and are here to help you. So thank you. questions?
Well, thank you very much, Pat, for this beautiful lecture, and I hope everyone enjoyed the message, which is take care of yourself again. And I love the message. If somebody offers you help, get it. If they don't offer you help, help is there. Look for it, and you can get it. Now I'm gonna introduce my favorite neurosurgeon, Dr. Oliveira, and he is going to be talking about epilepsy surgery in a minute. Dr. Oliveira.
Hello, good afternoon. And first and foremost, I'm delighted and I wanted to say thank you, everybody, for inviting me over here. Thank you for having a microphone that I can adjust to my height. Thank you. It's very illuminating for me to be in a place like this in an afternoon like this on a Sunday. First, for two things, because as you can see on the screen, we are in a big endeavor now. We're trying to develop a neuroscience institute along with Art and Health Institute that goes from Ocala all the way to Sebring, includes 13 hospitals, and includes everything that has to do with neurosciences, including neurosurgery, neurology, which includes epilepsy, stroke, neurocritical care, interventional neuroradiology. So very important for us to connect, the plans to go into the airport, the advice for planned pregnancies. That is the things that you have to learn and you have to apply. Because epilepsy and neurosurgery have been related, to each other since the beginning of times. The first neurosurgical interventions done in the history of mankind were, one, when somebody had an epileptic attack, seizures, and they had to do a burr hole, a trephination to let the evil spirits out, right? And second, when you get either a rock or a spear or an axe on your head, and people will try to save your life, which also can be a reason to have epilepsy. We will go over that in a few minutes. To put it in perspective, to me today is awesome, and you will see the reason for it at the end. My last video was made in 2018, 5 years ago, and the last line of that video will summarize everything that I'm going to say today, because it kind of like it goes back and closes the loop and the circle as to how epilepsy and neurosurgery are buying together. I want to make a disclaimer. Two, one, the first disclaimer is I am a neurosurgeon that operates on people with epilepsy. I am not an epilepsy surgeon, which is a little bit of a different thing. Epilepsy surgeons, we are part of a team. And like someone said, luck, you have to look for it, right? Like my dad used to tell me, your family, you're born with it. Your friends, your team, the people around your husband that's going to treat you like a princess. Those things you have to look for themselves, and they own them. So for me, today, I've learned so much stuff today. I've been here since the first presentation with Dr. Benedict, and I learned more on epilepsy today than I did on my 7 years of neurosurgery training, and then on my skull-based fellowship and cerebrovascular fellowship to treat complex diseases of the brain. So I think that what I will do is that I am going to kind of like give you the easy part. What the neurologists do, guys, what these people do for the epilepsy patient has no comparison. It blows my mind how committed, how dedicated, how deep they go into these things. And we, as part of the team, have kind of like the easier part. We come here to help sometimes in the diagnosis, and we help sometimes in the treatment. But I'm going to give you just the easy version of what I've learned over all these years. It's not going to be as complicated as what the neurologists know about this. This is very simple concept of epilepsy. I think that everybody knows more or less what epilepsy is, how common it is, how it affects everybody, no discrimination, no age groups, no gender, no race, no ethnic background. it's something that sometimes can be cured, and when we can cure it, we're very happy to be part of that effort, and sometimes cannot be cured, and then you have to plan ahead, as it was just stated on the previous presentation. The symptoms of epilepsy, everybody knows what the symptoms are. We've gone over at length today as to what can be the different kinds of seizures, what can, be a seizure or not. The types of seizures, like Dr. Becker said when he was talking about stroke, same thing when we talk about tumors. I always tell doctors and non-doctors or everybody in my family, even my daughters, yes, dad, you just as your brain surgeon, you think you're right. But this is true. The brain and the central nervous system is like real estate. It's location, location, location. It doesn't matter if it's a bullet in your head, if it's a blood clot, a stroke, a tumor, a scar, a lesion, or an epileptic foci. Your symptoms are going to be related to where the symptoms are. It's very topographic. That's why Dr. Decker was talking about geography in the brain, because it means a lot when you try to locate the seizures. The two little brains on the corner there will illustrate a difference just on looking at them as to when do you have a focal seizure and when will you have a generalized seizures. And as you know, focal seizures can also get generalized. So generalized, of course, you can see how that brain is about to explode with all this electricity. And this is what happens when you have any of these common types of generalized seizures, which I'm not going to go into detail on each and every one of them because you know them probably better than I do. Then what happens? Okay, so you have programs, you have the ictal stage, you have the post-ictal stage. Also, a participant earlier was saying, well, yeah, the EEGs, nobody will do an MRI on my patient. That is correct. Fortunately and unfortunately, I think we're privileged in America of having the resources and the will to solve the problems. And the resources are very important, as you're going to see on my presentation downstream. You will see how technology can be so good for us, how video taking on a phone has become and should be part of the chart when you document what kind of seizure the patient is having before you only rely on the description of a bystander or somebody that probably didn't even know what was happening. As a parent with a child sees the attacks one and over, eventually they will give you a very adequate and accurate description, but all the people will not know, so having that phone helps. Having an MRI, having technology that can help you diagnose and can help you treat is paramount. So, for me, coming from Cuba, where I did my med school over there in the 90s, my whole med school from 1990 through 1996 is a 6-year degree over there. I never saw a scan of the brain. There was no scans available. We had to do brain surgery based on physical examination, history, when somebody saw, localize it depending on the symptoms, but we couldn't really look at the lesion. 30 years later, we've come a long way, and that's why, by the way, one of the reasons I try to speak slow is because of that, because, I can speak Spanish very fast, a little bit of Russian, because they touch Russian there, but I never learned English in school, so I have to go slow so you guys can understand, but if I say something that you don't understand, please feel free to tell me. So, very important because of the complications. And the other doctors talked about what can happen when you have seizure, why is it so important on the patient's life and the family and everybody surrounding these patients. Then what can cause seizures? And this is what, the difference between the trephination that the Egyptians will do. By the way, I don't know if you know, but the Incas did more trephinations than the Egyptians. In the 1500s, when Pizarro conquered the Incas in South America, first they had more mummies. Now they're discovering that they had more pyramids than the Egyptians. The mummies was kind of easy. They didn't have to mummify the bodies because it was so dry over there that they would not rot, so they would just dry out and become a mummy by themselves. But they found now, because of all those mummies, that a lot of those people had brain surgery. They had better results in the 1500s in the Andes in South America than the surgeons in the Middle Ages in Europe. And you know, because you see a trephination, and you see the edges of the bone are healed, they're not sharp anymore. So that patient did not die at the time that the skull was open. It remodeled the bone along the way. So very interesting when you start differentiating epilepsies as a seizure disorder, an epilepsy disorder, as to when you come to a neurosurgeon with a structural disorder. And then it's when we really have a more active role in the treatment, because then we see the target and we can act upon the target. The difficult part is to select the target, is when then the neurologist says, Dr. Oliveira, I have this patient, this is coming from the frontal lobe. Like Erasmus was saying, yeah, got a cavernoma in a location, but if the neurosurgeon goes after the cavernoma, it's not going to do anything for the seizures, because the seizures are coming from somewhere else. And speaking of cavernomas, coincidentally again, the last case that I'm going to show you, surgery that I did a month ago, is precisely a cavernoma. But in this case, it was the reason for the seizure, so we'll see how that went. This is what happens in the world of neurosurgery, right? So structural damage, it could come from anything that irritates that brain. So irritates the brain where the neurons are. So if you have one of those strokes like Dr. Decker was showing, with a hemorrhage in the middle of the brain because you have high blood pressure, that probably is not going to give you a seizure. If you have a tumor or you have a hemorrhage in your cerebellum in the back of your head, that probably is not going, it could kill you with hydrocephalus or pressing on your brainstem and stopping, making you comatose and stopping your breathing, but it's not going to give you a seizure. So seizures usually, like in the first scan at the bottom on the left, when you have blood on the surface of the brain. Blood, guys, is like acid to the brain. It irritates the brain to no end. So you can have seizures when you have subdural hematomas. This is the one that you can, actually, that's a very interesting case. Let me see. I'm going to try something. So if you see here, that's a brain inside of the skull. Here there is some air and there is some staples. So we operated on this patient on this side because he came with a big subdural hematoma, which is a collection of blood between the brain and the skull. And then what happened, the other side, which didn't have it at the time, once this shifted, developed another one. So this is a pre-op subdural hematoma. This is the post-op subdural hematoma. Then you have here another scan in which you see the white, the blood, really not on top of the brain, not inside of the brain, is around the brain in the subarachnoid space where the CSF fluid is. That's usually called a subarachnoid hemorrhage, usually because you have a ruptured aneurysm. Could be traumatic too. That can give you very bad seizures because, again, your brain gets very irritated about that. That's why when you go to the hospital with some kind of traumatic brain injury and you have any blood around the brain, everybody's going to give you anti-seizure medication. And if you start seizing because of one of these things and we cure it, you don't seize again. Okay? Then the other poor scan on the right is obviously a patient that eventually died because you see there's structural damage. You have blood there in every compartment, inside of the ventricles, inside of the brain, in the subarachnoid space, in the subdural space, and the epidural space. So epidural hematomas, another one. They do not give you seizures because the blood is on top of the dura mater, which is the membrane that covers the brain. It doesn't irritate the brain. So little perks from the neurosurgical perspective. Now, when are we involved in epilepsy with the neurologist? When we usually tend to tell other people what to do, except in epilepsy, which the neurologist tells us what to do, which is a great dynamic. It humbles them down. And then the diagnostic part of it. is when you do all the procedures that I'm going to show you to try to find, is it real? Where is it coming from? What can we do about it? That's the planning stage. And then when you have actually a target. These pictures here is a patient who's in the hospital right now that I saw this morning before I was coming over. That patient is having surgery on Monday. Why? I'll tell you a story. It's interesting. So, elderly patient with terminal cancer, esophageal cancer. Very rare. I've seen in 20 years of practicing neurosurgery, I've seen probably 2 or 3 esophageal cancers that go to the brain. Now, the patient is now on the last stages of his disease. He's got metastatic lesions on the liver, the lungs, etc. And now for the first time in the brain. How do we know that? He went to the hospital having a seizure. And when he had the seizure and they knew he had cancer, the first thing that they did was scan his head. And we found this lesion right there, surrounded by edema in front of the motor cortex. It's right here, and then, like I said, right, this real state, movement is here, sensation is here, frontal, parietal. And then he had a drooping of the mouth. He couldn't talk right because he's in the left side. 98% of right-handed people have speech on the left. 80% of left-handed people still have speech on the left. Left is very, very important for speech. And then he couldn't move the right side of the body. You know, he's having a seizure because he's having a stroke. No, he's having a seizure because he's having a metastatic lesion there. So he told the oncologist and said, well, but his life expectancy is not very good. He's already a DNR. And I'm like, well, that is in the surface of the brain. I do not have to go through any good brain to get to it. I can open the skull, get that lesion out of there with minimal damage for the patient, with minimal operative time. And guess what? Whatever time this patient has left, he's not going to have edema that is giving him the paralysis on the other side. He's going to be able to talk because the speech is not going to be impaired, and he's not going to die having seizures because I will give him that quality of life over the last few months that he's got left. So he's having surgery tomorrow morning. I just wanted to illustrate that because it's a real case, and these things are real. Now, what can we do as surgeons to help the patients and the team to help the patients? So one of the most important and popular things that we do is the stripped grids and also the depth electrodes. This is how it usually looks on an X-ray when you have a grid over the surface of the brain, and those electrodes help mapping where this seizure is coming from. These are depth electrodes in which you not only have an electrocorticography, meaning that you're registering the cortex of the brain electrical activity, but you also have depth electrodes that are going to be measuring other areas in the deep part of the brain to localize those epilepsy foci. So those are invasive. Those have to be done precisely because the reading is going to depend on the location, and they require an operation before and an operation after, and they have obviously the risks of surgery because surgery can induce seizures because you are messing with irritating the brain yourself. Before you cure it, maybe you have to stir it up. But the important thing is that technology, which one of my disclaimers is that any technology that I have on my touch, I have nothing to do with those companies. I don't have any financial relationship with anybody, just for the record. But yes, we need that technology. We need the technology to plan, and we need the technology to execute. And the ROSA robot has been instrumental in trying to place these electrodes in the right trajectory, in the right location, and it has to be done by expert neurosurgeons that have special training on these things. Other things that we do are different surgeries that do not require electrodes. In this case, these are therapeutic, they're not diagnostic. So like corpus callosotomy is vagal nerve stimulation, responsive nerve stimulation, laser, interstitial thermotherapy, and multiple sulfate transections. These are different surgeries that are usually a resort we have to help when there is a drug-resistant epilepsy, as drug failure, like it says, there occurs in 25 to 30% of all epilepsy population. So what is pretty much this is the most important and the more commonly done. When you see the one at the top, we go in between. We can go through the brain if it's necessary. Sometimes we go in between the hemispheres to get to the corpus callosum, which is that big white thing at the bottom that communicates one area of the brain with the other. Then we cut those fibers selectively so you don't spread seizures from one side to the other, especially for drug attacks. And it has very, very good results, but it's got, complications and risks as every brain surgery. Vagal nerve stimulator is an operation that I love because it can be done with very minimal resources. All you have to do is basically open the neck of the patient. We do regularly for spine surgery, and then you locate that vagal nerve in between the artery, the carotid artery, and the jugular vein, and then you wrap 3 electrodes around it, and then you put that wire under the skin to a generator / battery that is in the upper side of the chest there under the skin, and then the patients get much better. I have never heard of a patient that at least did not have some relief. It's very rare to hear a patient that says, no, it did not work at all. If it did not work at all, something was wrong one way or the other. But I always tell the patients too, this doesn't mean that it's going to get you 1, seizure-free, or 2, medication-free. When you do vagal nerve, you're trying to either decrease the amount of seizures that the patients have regardless of the medication, even if they stay with the same medication. 2, if you can decrease the amount of medication, because sometimes you do it only because of the side effects of that medication, then that's a win, because you can control the seizures with less medication and the side effects improve, also improving the quality of life of that patient. And if you get medication-free and seizure-free, well, we throw a party, because, that's the maximum that you can get. We only implant the device. We rely on the neurologist, then on programming it, and then winning the medications off, depending. It's a trial and error. You guys are more versed in that than anybody else. The dosage can change. If the dose is maximized, you get a second medication, et cetera, et cetera. When you try to weigh it up, you do the opposite. But the neurologists are the ones that do that. Like I said, my part of the job here is the easy part. It's their part, really, the one that is very difficult. So responsive neurostimulation is kind of like the same, but you do it inside of the brain, stimulate the areas that detect when there is a seizure that is going to come around, and then stimulate that area to kind of blunt it, the same thing that the vagal nerve stimulator does. Interesting, always on the left. Don't do a vagal stimulator on the right, because then you will not stop seizures, you will stop the heart, and you don't want that. Just, the heart is just a pump that pumps blood to the brain for the brain to work, but it's important too. Laser interstitial thermotherapy is coming along. That is also invasive. You need navigation. You need stereotactic technology. It's technology dependent. There's a lot of fuss about it, the same way that there is a lot of fuss about focused ultrasound. But this is invasive. Focal ultrasound is not. Multiple subfield transections is a procedure that I have particularly never done myself, but I know that some people swear by it as giving small incisions in the membranes that cover the brain. That's what's called subpeel, the PIA. It's the membrane. There are 3 membranes that cover the brain, and this is a little bit of anatomy here because it's going to be interesting at the end when you see that carcinoma. You have meninges. you have an infection or inflammation on the meninges, it's called meningitis, right? If you have a tumor in the meninges, it's called a meningioma. But meninges are three. You have dura mater, which is Latin for tough mother, because it's very fibrous and thick and covers the brain and protects it. You have arachnoid, because like in my feet, my big fat Greek wedding picture, and like everybody who is not Greek wants to be Greek, and if you really dig deep into anything, you're gonna find a Greek root for everything, right? Arachnoid, because it looks like a spider web, and it comes from the Greek. But the Romans will not get the Greek get away with it, so they have to invent another one. And then pia mater, which is basal matter. So we have Roman, Latin, Greek, and then Latin again. The pia is the one that goes about, along with the cortex in every cell site, in every gyri, kind of like the brain is stuck to it from underneath. So when you're doing surgery on the brain, you want to stay under the pia, so you don't go to the other side where you don't know what you're going to find. Could be the optic nerve, could be the carotid, could be the cavernous sinus, could be very dangerous if you injure any of those things. So these are some of the future technologies that are being investigated. There are papers out there written about. I don't really have any experience of any of these, but it's coming to a hospital near you. So there's a lot of hope. There's a lot of development in this area. And these are things that we as surgeons will be looking into in the future along with the neurologists. Now, what is really the interesting part about doing brain surgery when you get to do either anatomic dissections or functional hemispherectomies? This is a very big operation in which you really take the areas of the brain that are damaged, with no hope of repair, and they just develop being scarring and more scarring and generating more seizures. So you basically amputate that area. It could be anatomical or it could be functional, like you see in the second. Why that is important? Because now we have technology that actually help us be safer for the patients and locate these areas with much more precision to do the surgeries better and cleaner and more helpful. Now, pause it for a second. We're going to be a little bit back and forth with the technology people down there. I love technology and I love technology people because I work with technology every day. But I want to show you a couple of videos, and you have to put yourself in the time. So this first video is going to show one of the big resources that we have today as opposed to we had when I trained. I finished my training. I started neurosurgery in 2003, 20 years ago. And then I finished my training in 2010, and at that time, none of this existed. The first part, you can see how it used to be when I finished my training, and now how it is now, 10, 13 years that after I finished my neurosurgery training. So we're going to be going back and forth. I hope that if you guys see blood after lunch, you're not going to be, having, hopefully no one has a seizure, So can we go back and play that video? The video shows you when I was still in Florida Hospital, was not admin health yet. This is how it used to be for us. This is brain surgery at its best back in the day. And me being short and stocky, 12 hours, 20 hours of my hands up, it was impossible. So this is what we have now, and this is honestly has made a huge difference, at least in my practice, because that allows us, you can stop it there. This allows us to not only execute that plan at the same time. This is a robotic arm. Robots in neurosurgery, they really don't do the surgery, right? They follow us. We tell the robot what to do. This robot, what it does is it follows my hand, and you're going to see it on the last video, kind of like it shows me the way I want to see that I cannot see. Because the important thing with brain surgery is to know what is there that you don't see, so you don't damage it once you get there. Because once you damage it, it's too late. You just don't want to damage it. And as you can see, the important thing for this technology is it maps out all your fibers in the brain. You can see it actually gives them a certain colors. The ones that go up and down, they're blue because of the sky. Ones that go across or red is the corpus callosum. Usually you can see them over there on top of the ventricles, and ones is a red, it's kind of like stops the red fibers that go from front to back. And that way you kind of know which are the fibers that you don't want to miss or you don't want to hurt. If you have a lesion or a tumor that is very close to the fibers that move the body on the other side, if you can avoid it, you're going to spare that patient a paralysis. So sometimes in the past, we used to choose like the shortest way to get to the lesion that is causing the seizure. Now we sometimes go a longer route to go around and preserve those structures and give the patient the ability, to survive surgery without a residual deficit or paralysis. You can see a more detailed picture here of how these fibers can be depicted. And you remember when you do functional hemispectomies, you can actually map out exactly what kind of fiber goes up and down, which are they, and sometimes you don't even know they're not going to be on the place you expect them to be because the tumor or the lesion or the abscess or the bullet or the blood clot have displaced them, moved them, stretched them, and then you're thinking on your anatomy that you're going the right way and you're not because those fibers are now on the way where they were not supposed to be. So very, very interesting. This is precisely a tumor that in the area of that cavernoma that going through a little tube through the cortex, you can see how we can plan that trajectory to get to the yellow tumor at the bottom without injuring any of those fibers. This is, you can play it, very short video that allows you to see how this technology has evolved in the way that the quality of the imaging, the amplification is better than the microscope, to be honest. And then that gives the surgeon the ability to see more detail and to see more of the surroundings because of the depth of the field. You're focused at the bottom, but you're also focused on top, so you can see everything in between. That makes a huge difference for us. Then you get to what we call focal resections, temporal lobe epilepsy. Usually when you have mesial temporal lobe sclerosis, the neurologist diagnose it, they map it, and then tell you go there. You do the selective amygdala hypercampectomy, which is a beautiful operation because it's got very good results. And obviously, those are things that for us are very, very meaningful because we really can help the patients with those. And then we come to lesionectomy. Lesionectomy is when we're going for the lesion, where in this case, you're going for this. So from the front, temporal lobe, right side, this is the temporal lobe, this is the frontal lobe. The corpus callosum is here. This dark spots there, that's the carotid artery, which goes inside of the cavernous sinus when you have all the nerves that go and move your eyes. And then it gets out of there and up here, the carotid divides in two, medial cerebral this way and anterior cerebral this way to join the other one from the other side and go in the center. So in order to get here, you have to either take two routes. You go through the sodium fissure that divides frontal and temporal and follow those blood vessels until you get here. Good because you can see everything that is dangerous, but it's bad because everything that you're looking at is dangerous, right? The other way is using technology, navigation, and the robotic arm to go around through the bottom and up to be able to get these from the mesial side, medial side of the temporal lobe without getting to the structures that you can potentially damage. That patient came to us for seizures. And the neurologist told me, it's the cavernoma. That's the cavernoma. And that cavernoma is the reason for the seizures. So, and bled. So that means the cavernoma that is going to bleed. Cavernoma, for those who don't know, is cavernous malformations, like a varix, like a big blood vessel, usually a vein, that gets dilated and then bleeds a little bit and reabsorbs, bleeds a little bit, reabsorbs, but eventually could bleed a lot. And that continues to irritate the brain. If it doesn't give you problems, we don't do anything about it. Because it's not a tumor, it's not really a problem that will need surgery for, but if it starts giving you trouble, then we take it out. This is that operation, which I did like a month or two ago, in which I tried, because I know I'm using this technology now, so I'm taking advantage of not doing a big surgery to go around like we used to do, very pointed, very small. This is the temporalis muscle, the one that moves your jaw when you open and close your mouth here on the side. Then your ears here and the face is there. And this is that Seizure fissure. The frontal lobe is here. This is the temporal lobe on the right side. And we're going to take this little piece of bone to go under and towards behind the eye, towards the center of the head. This is once we take the bone, what you can see there is that membrane that covers the brain, that do not matter. And then this is the small little piece of bone that we were able to take off. As you see, there's the muscle still there, so we can reattach it so the patient can still chew up and down without having that excavation for from the muscle atrophy. This is actually when we put the bone back, and then we just put the muscle back. That thing that I'm holding there with my forceps is a little fat part you have there that allows your facial nerve to raise your eyebrows. So we preserve it. The patient doesn't have a problem with the eyebrows, and she continues to be pretty as she was before the surgery. So this is now that surgery, actually, in which you can see, play please. So this is the bottom of the brain, in the same way I showed you the outside. This is the brain, and we're going, this is the surface. We're 3-4 centimeters deep. Behind us is that cavernous sinus, is that carotid. You move it to like 1 minute. I got to the blood clot and the cavernoma, so I'm now pulling out of there, trying to preserve the brain around it. If you see down here, this is whole bone. This is the eye is this way, and the ear is this way. And we're almost all the way to the center. Go to 2 minutes. And here you start seeing that there's really nothing behind now. That's the pia from the inside. Remember when we were talking about the pia? Behind that pia is the cavernous sinus, is the carotid, is the optic nerve. So staying there, I'm safe. And the patient is safe. And the cavernoma is out. And she's not going to have seizures. So it's a win-win for everybody. Again. So that is towards the end of the surgery, in which I'm cleaning everything out, making sure that there's no bleeding on the brain. All the brain around looks really good. So time to close. And then, beautiful. Okay.
On your cutting edge medical.
So I want you guys to have that vision of what is it that neurosurgeons do when it comes to epilepsy. I hope I didn't tire you much, and I didn't go into many details that are, nobody had a problem with the blood, that's good. So this last video, I want you to listen and watch, because it's a real story. It was on the news in 2018. It's the same robotic arm that I'm using today, and this is one of my first 2 cases, so January 8th of 2018. I never forget that. And right now we have more than 500 cases, more than 300 brain tumors operated on. We're top 5 in the world in the number of cases done both for brain and spine with this technology. And at the time, you would see when they interviewed me, I talked about everything except for epilepsy. And then at the end, watch.
On your cutting edge medical technology making its way to the Tampa Bay area.
Fox 13's Dr. Jones shows us tonight how technology from the International Space Station, saving lives here on Earth.
The day after Hurricane Irma struck, like most Floridians, Ken Lambert was outside picking up the pieces.
I was in my yard just cleaning up small limb debris, and
I noticed a numbness in my right hand and a portion in my right face.
What he didn't know is that months before the monstrous storm made its way up the state, a very different kind of storm was silently brewing inside his skull.
When you get the diagnosis of a brain tumor, it'll bring you to your knees pretty quickly, in more ways than one.
To remove the cancer, Lambert became one of the first in the world to undergo surgery using the latest model of the synaptive Modus 5. Its robotic arm is derived from technology used on the International Space Station. But instead of harboring tools to repair satellites, this movable arm contains a digital microscope.
With this new technology, we can have the best imaging, the best views, and actually the best way to operate on our patients in the brain, in the spine, in ways that we couldn't do before.
Florida Hospital neurosurgeon Dr. Raul Oliveira maneuvers the robotic arm using a special wand. Within its Bright Matter software system, preloaded MRI images of nerve tracts in the brain can be accessed in real time, allowing surgeons to navigate around critical structures while operating on the brain.
Overall, it's going to improve all kinds of cases, tumors, vascular malformations, strokes, or even traumatic injury.
The enhanced precision may lead to a faster recovery.
I was able to do the Gator Chomp, which was my alma mater, and watch the national championship football game within 2.5 hours of surgery that night.
4 days after the procedure, Lambert was back to work. You can see in this post-operative CAT scan, the dark area is where the tumor used to be. And while he's happy with his outcome, Oliveira says this is just the beginning.
It's not what it brings now only, it's what it holds for the future that it has me more excited than anything.
For the Fox Medical Team, I'm Dr. Joette Chiavinka.
Well, Dr. Joe also says the technology is helping people with epilepsy, breast cancer, and spinal tumors.
Little I know back then, so when I was, requested to come and talk to epilepsy, I was like, wow, 5 years later, here we are. And it's kind of like a prophecy, because we're really looking forward to continue to cooperate with the neurologists and all the organizations that actually make this collaboration and that team building possible. So very grateful for that, and thank you very much. Any questions? See, brain surgery is easy. Come on.
Thank you to all our speakers. Most of you know me, I'm Mary Gomez, and I'm usually in the background moving things around like Pat says, the planner. But I have the privilege today of introducing our host, Hind Katani. Dr. Katani is very special to us. She's a board member at EpiLEpsy in Florida, but she also cares about her patients, and that's why we love having her on our board. And this is why I will do whatever it takes to put something like this together for her. So please, a round of applause for Dr. Hind Katani, our final speaker.
Good morning anymore. Thank you again for being present here today on a Sunday, and thank you for your dedication, and thank you for your collaboration, and thank you for your participation. So epilepsy is very dear to my heart, and I believe you learned a lot about where seizures coming from, how we can diagnose them, what to do for them, medically and surgically. But I want to touch up into a different topic, which is what are the stigma around epilepsy, and what can we do to raise awareness? So I broke down the lecture to a couple key points that I'm going to go over very fast so we can move on to question and be more interactive. So the first one is, sorry. So I'm just going to touch on a brief introduction about epilepsy, statistic, prevalence, the type of seizures, how we manage seizures, medication, and other options that are offered to diagnose and to treat seizures. We're going to move on to the psychological challenges and the impact of seizures on mental health, the fact that living with unpredictability can be very, very challenging, the social isolation and relationship in the individual with seizures, and the stigma, the misconception
how historically seizures was perceived in the past, and the common myths versus facts, and how the stigma affects people living with epilepsy. And of course, we have to talk about the workplace discrimination, what to do about that, the education barrier, the social exclusion, the self-esteem issue, and the solution to the problem. So, not to dwell too much on the definition, we know what is a seizure. A seizure is a manifestation of abnormal brain tissue that miscommunicates and misfire, cause the individual based on wherever the focus or where is the irritation in the brain to cause the individual feel symptoms that can range from a smell, taste, just a feeling or a sensation to a full tonic-clonic seizure, the one that everyone knows as grandma seizure. So it's not a single disease, but it's a spectrum of disorders, and it's one of the most common neurological conditions worldwide. It affects a lot of people, 50 million globally, and approximately 2.5 million cases annually are discovered, and that's considering that in a lot of countries it's still undiagnosed and we don't know about them. It doesn't discriminate age, ethnicity, or anything else. It's more frequent in young children and after 60 years old. So there's two types of seizures. Briefly, there's generalized, means it starts from both sides of the brain, and there's the tonic-clonic that we see that is clear a seizure, and there's the absence where you're zoning out or there's a behavioral arrest, and it's part of the generalized seizures. Then you have the focal seizure. It can either alter your consciousness or not alter your consciousness. So one type is the focal aware seizure, used to be called simple partial seizures, and the one that used to be complex partial seizures are called now focal impaired awareness seizures. So what are the medical challenges of epilepsy? Seizure control can be very difficult, but the good news, if the individual who's suffering from seizures is treated properly from the get-go with the right medication, 70% of these patients could be seizure-free on a monotherapy. Unfortunately, 30% will develop drug-resistant seizures. But the good news, there's other options for them too, to provide them with at least decreasing seizure frequency, or sometimes either seizure freedom. Then with management of seizures, it's important to know that it has to be some lifestyle adjustments. They don't have to make the individual living with seizure feeling like they're disabled, but they have to make some adjustment for safety. And they have to always have a seizure plan, which is emergency management. So as far as medication, Dr. Vernier mentioned earlier, there is no medication without side effects, and even vitamins can cause issues. So, but the most common side effect is the dizziness, can be weight gain, could be a long-term affecting your liver, bone density, and each individual response to medication have different type of side effects. So that's why it's very important to adjust it based on each individual, because everybody's different. So how do we navigate through the diagnosis and the treatment options? So it can be complex. We seem to be easy to have an EEG and an MRI. It's not always the case. And now trying to have the other testing like SPECT, other more complex testing can be very challenging to obtain. And the treatment, also finding the right medication, considering that some patients don't have the luxury to see a seizure specialist from the beginning, and they may have tried medication that didn't work for them and their seizure became chronic. And then the access to alternative treatment, seizure, epilepsy surgery, or devices that help with seizures. I'm gonna touch base on the psychological challenges of epilepsy. So the epilepsy can be very challenging in many ways. Because of the predictability of when the seizure is gonna occur, it can cause a lot of fear, anxiety, depression, feeling low self-esteem, and it is important to acknowledge them to be able to address them. It can impact the individual in their daily life and their career, education. Obtaining what seems very simple to everybody else can be very challenging with people with seizures. Then it can cause also social isolation, and it causes a lot of stress upon family and caregivers because they don't know what to do sometimes, because it's frightening, because they are not very well educated about it, and maybe they don't even have a seizure emergency plan. And it could also pose a problem and form a new relationship, having the fear that you're going to be rejected, and therefore you just isolate yourself. So Asian beliefs about seizures. Unfortunately, it used to be believed that you were possessed, there's demons, there's witchcraft, and all that nonsense. I'm from Morocco, and some places that can guarantee you they still believe in that. Unfortunately, it's very sad due to lack of education and awareness in many places. And it's in the 19th centuries, 20th centuries where I found out that seizure is a neurological condition, and it's the one condition in neurology that you can cure. Therefore, I chose to be an epileptologist because we can change our lives, or your lives too. So there are common myths and facts about seizures. Epilepsy is not contagious. People with epilepsy, they don't suffer from intellectual disability. And patient with seizure, they should never be restrained during the seizure, or nothing should be put in their mouth when they have a seizure. They should just let the seizure ride, and usually most of seizures stop within a few minutes. I think we spoke about that, not to reinforce it, and that there is a workplace discrimination we have to be aware of so we can address it and find solution. And it comes from two parts. The employer may fear that the patient is a liability due to lack of understanding or knowing they can accommodate them with safer environments, and they can cause career limitation for the same reasons. Then also there is a lack of support in school. Unfortunately, there has been some campaigns and dedicated nurses and dedicated doctors to go into schools and educate the school nurses to avoid the stigma and the fear from seizure, and to properly have an action plan for seizures. Again, I'm insisting in this because it's very important. We feel you, we hear you. It can cause a lot of social exclusion and low self-esteem issue, but there are solutions. So now, talking about all the issues and the problems and the challenges with seizures, we have to have a solution. And to most of problems, there is a solution. You just have to believe. So empowerment is important, and the only way I strongly believe it can be achieved is through education. You have to know what you're dealing with so you can have an action plan, and you understand it better so you can address it better. There are awareness campaigns like this one, and there is walks, there is a lot of other organizations that I'm going to list, and I'm going to provide with website links to visit them, because they can provide you with a lot of support. And there is a lot of also educational resources for patients online and through these organizations and foundations. And of course, training professionals, which include not just doctors, it can include nurses, mid-levels, physician assistant, medical assistant, general public about epilepsy, action plan, and understand what is epilepsy. There is also support groups, and I strongly encourage anyone who has epilepsy to join the support groups because you don't feel alone. And also there is a lot of help and support, and also information you can get from other people who suffer from the same condition. And there is a lot of community events that I encourage everyone to always join to learn more and again to participate. And I personally work with other healthcare providers to encourage more education and knowledge about epilepsy and what to do. I also want to let you know that there is the American with Disability Act that is there to protect you. There is a couple laws that you need to be aware of so you don't suffer from any form of discrimination. There are a lot of organizations that work very closely with legislators to have policies advocating for epilepsy patients. And I encourage you to also self-advocacy. So the key point of my very brief lecture was that we have to understand first what is epilepsy, the medical challenges, the psychological impact, the stigma and misconception, and that there is solutions, and we have to know what are the strategies that are out there to help you overcome this challenge of living with epilepsy and getting the help you need. So what we should do and what we're looking to do and working together and doing is raising awareness, promote inclusivity, advocate for change, encourage you to educate yourself, be very knowledgeable about your condition, the medication you're taking, the other options that are out there to help you, and the social help that is out there for you. And contribute as much as you can and volunteer for these organizations as well, and give you some form of strength and reason to fight your epilepsy. This is the references I have for you, and I have I listed the Epilepsy Alliance, Epilepsy Foundation, the World Health Organization, the CDC, and where to research if you have questions about anything that occurred to you regarding epilepsy, but not just a random search in Google. There are some reliable website, and because it's a foundation organization that screen pretty much the information they're giving you, so you're following well-controlled material. And again, these are some of the support group. I didn't mention all of them, but these are the ones that I'm more familiar with. So I'll encourage you to visit them. So this one I'm going to read for you to conclude today, that your strength and resilience in the face of challenges are truly inspiring. Remember, knowledge is power. By educating ourselves and others about epilepsy, we not only dispel myths and reduce stigma, but we also empower everyone affected by this condition and their loved ones. Awareness is the first step toward change. Together, through understanding and support, we can create an inclusive environment where everyone could thrive. Let's continue to learn, share, and advocate for a brighter and more inclusive future. Thank you very much for coming again, and thank you for all your support. To do something a little less formal and engage everyone who has something to share, an experience or something to say, or want to perform a dance or whatever you guys like. We have a volunteer. Applaud to the volunteer.
introduce yourself.
Hey everybody, my name is Marcus. I turn 32 in March next year. I've been dealing with this whole condition since 2010. The height of everything peaked right after I graduated from Marine Corps boot camp. And in Dr. Katani's presentation, she hit a lot on awareness. And that does seem to be an area that is lacking pretty hard. You don't walk around every day and see people drop having seizures left and right. So a lot of people don't really know what it is we in this room have to battle and deal with. And my brother's become a big supporter of mine. He's here today. And he's kind of recently shown me to be a little less afraid of getting out there and talking a lot about this, because it is kind of a hard thing to deal with. People with battles and disabilities and in areas of their lives don't really want to share those things. Prior to meeting Dr. Katani, I had gone through, I want to say 7 or 8 different neurologists. And there's a strong hesitancy to have their patients dig and look deeper into what can be done, what they can do. And after, I want to say, my second visit with Dr. Katani, she helped me learn a lot more about what was going on. We changed some medications, we tried some different things, and in the last 12 years, I finally made it past a 12-month span of not having any seizures. So thank you, Dr. Katani, for all your help and support. And if anybody else wants to talk, you should, because like I'm saying, it's hard to get up and say something about what you got going on. So, thank you.
Hello. Cool. My name is, let me get out of that light. My name is Chris Riggs, and just like him over there, I was diagnosed with epilepsy in 2010, I believe. And it was, let's see here, right before my junior year of high school. So it wasn't that much of a, I didn't have to deal with so much of a difficulty because, you know, nothing is really possible without the support and love from your friends and family. And, you know, the first 2 years when I had it, it was really hard to accept, wondering, where am I going to go after this? And am I going to achieve what I want to do? And at first, you know, it was very difficult. But like I said, once you have like the support and love from your friends and family, it makes life so much easier. And when I went to college in North Carolina, that's originally where I was from before I moved here about 2 years ago. Yeah, 2 years ago. And I went to college for my music education degree. And those 3 years, it was really tough. Having like seizures, 1 to 2 a week, and made me miss a good bit of classes. The seizures I have, by the way, is the tonic-clonic grand mal seizures. And I had to end up leaving early for a medical withdrawal, just so I can make sure that I can have this more under control, and actually pass to become a music teacher. And, oh, a second. Now, if you're wondering what that cough was, it's, I have a vagus nerve or vagal nerve stimulator that after about 10 years, I was finally able to get a surgery for an implant, for the implant rather. And it went from, or taking my seizures from, like I said, 1 to 2 a week to 1 to 2 every 3 months. And it's amazing what that can do for someone. And as of this year, with with a good amount of prescriptions, medicine, and this itself, I'm actually going to be able to go back to college next year and finally able to finish it. I did get accepted. Now all I got to do is just go and audition in December, and I'll be able to do something that I love. And like I said, all of this, which is really important, is with the love and support of your friends and family, and the neurologists who really want to see you walk out that door and do what you want to do and live a normal life. And throughout my years in college and high school, and even to this day, whoever I meet, whoever I talk to, I do everything I can to raise epilepsy awareness. Because like he said, some people just don't really understand that. And some of them will instantly be afraid or cautious. They won't even want to touch you because of all the misconceptions. And that's why it's important for people like us and those around you to fully understand and tell other people, so that stereotypes or stuff like that is gone. I do what I can this month on Facebook to post articles and post about all that stuff. And like she said, with support group, there is a website that you can go to. It's kind of like, to sum it down, it's like a Facebook of epileptics. They got a phone app for it too. It's called myepilepsy.com, where you can find either people in your area or people anywhere around America, for example, who give what they've gone through, what they take to help them better. And there's plenty of articles on that website to educate you more on what you have, what you can do, all kinds of options. And I think that's it, because, yeah.
Any other volunteers?
Nice job, guys. My name is Tommy, and I started having epilepsy when I was 7, and I'm 26, so that was like 2004. If my math is right. And it's easy to talk about it when you're older, but when you're a kid and you have seizures, it's real, you don't have the vocabulary to say, I think I might have depression or anxiety, or I was in the bathroom because I had a panic attack, and things like that happen, and it feels like similar to an aura or a seizure, but sometimes it's not. And as I got older, it was easier to talk about it to friends and stuff, and it's kids mature and they're not bullying and stuff like that anymore. And when you're younger, I think it's really important to see a counselor or someone just to talk to maybe help you interpret what you're feeling. And luckily, when I got older, I had brain surgery, and that helps control the seizures. And I've only had one grand mal seizure since I was 13, and that was just because I was in college and was doing everything to lower my seizure threshold that you could do. And but yeah, it's a lot easier now, and I can talk to my friends about it and post stuff on social media. But like, when you're younger, it's really hard to just like live a normal life and like you don't even like have the words to describe what you're feeling. But yeah, no, it's good to share everything you know and like. And if you have like a kid that has seizures, make sure that they're not like hiding it to other people, because like I would go to birthday parties and like have a seizure in the pool and not tell anyone because like I don't want people to like think I'm weird or something. But yeah, no, it's good to just talk about it.
And now we have the courageous parents that want to talk about their experience. Because remember, epilepsy doesn't affect just the patients or the individuals suffering from epilepsy, but affect all their families, their loved ones, and people that cares for them.
For me, I just want to thank Dr. Katani. I always kidding her. I said, where you been all my life? Where you been all my child's life? Because we went from doctors to doctors to doctors. Nobody will listen to you. You explain to them what your child is experiencing, and they just or don't care or they no one acknowledge, or they see me like a less of a person that they don't want to acknowledge. So Julie was born with cerebral palsy, and I never knew that she had seizures. I would take it to the neurologist by the advice of the pediatrician, but the neurologist was so mean and so not caring that I didn't take it there anymore. So when the pediatrician told me when was the last time that she see a neurologist, I said she's not seeing one because he was this way and that way. And he said, no, you have to take it to the neurologist. So he sent me to this great neurologist, Dr. I forgot his name. And he said, since when she's having seizures? And I went, Julie has never had seizures. And he said to me, what do you mean? She's having a seizure right now. For me, seizures were like they were explaining, they fall on the floor, they shake, and that was seizures. But Julie was like rolling her eyes, staring, and not having, any reaction to things. I didn't know this about my daughter. So he started seeing her, put in the medicine, and went on and on. When he went to be a president of the epilepsy adult children, he left the practice, and Julie was sent to another doctor. The doctor saw her, but every 6 months gave her medicine and stuff. When she turned 22, it was referred to another doctor. At this time, Julie was having more seizures, more jerking, more stuff. And I keep telling the doctor, something is wrong with Julie. Something is wrong with Julie. She bangs on the headboard. She set up a nightclub. She cries. All these things that were happening to her. Oh, it's nothing, nothing is showing up and stuff. Okay. So keep taking her there. And finally he said, you know what? There is nothing I can do for your daughter anymore. Just like that. So I didn't took Julie for 2 years to a neurologist. This was the best doctors because my husband had a great insurance and we have the best doctors. When after 26 years, he loses his job and Julie started having this terrible jerkings and stuff, I couldn't find a doctor. I couldn't look for the doctor, and COVID ahead, and still couldn't find any doctor. So finally, somebody referred me to Dr. Katani. We made an appointment. First, they told me that she could see me because she was all booked. But I explained what Julie was going through, so they gave me an appointment. We went to see her. The moment that we walked into Dr. Katani's office, She knew what Julie was going through. She knew how to help Julie. And the only thing I wanted to say is, I thank her so much that she was able to this moment to help Julie. There is no time that I called and I said, Dr. Katani, this is happening, that she's not willing to bring her in, or, we'll see her on some medication and stuff. I tell her, I said, if you ever need a kidney, I'm the one who's going to provide it for you. But I just want to say thank you, because she's always willing to help me, to educate me, to just say the right words so I can help my daughter. So,
I guess somebody else want to talk. Thank you.
I'm Kenneth Casey, and I have had epilepsy all my life since I was a child. I'm 65 years old now, and I met the gentleman over here in the program when I was 18. And both of us have epilepsy, and we have bought a house together 36 years ago. I'm still working at a hotel nearby USF, and I went through surgery through Dr. Bebedes and Dr. Valley 9 years ago, and I'm doing well. And I was having seizures all my life prior to that, and they were pretty bad. Like I say, I take the bus to work every day, and I go shopping and stuff for what I need. We live around the USF in Busch Gardens area. I'm not used to doing this that much, but I'm doing real well. I've had 2 seizures since I had operation 9 years ago. One when my dad passed away, and another one a couple years ago. I see her, Dr. Katani, regularly, along with him and myself. And I can't think of what else I can say other than I went through life with this, and I'm still doing everything that a person tries to do in life, which is work and live in a house, and we share expenses together, and both of us just happened to meet through a program up in Chicago when we were 18 called Methodist Youth Service. And at that time, once you turn 21, you have to go on your own. And his counselor and my counselor got us 2 together to watch for each other and help each other. And there's a lot of things I still have to learn with the new technology. But I just came up here to give my story. And like I say, I'm went through surgery, and I'm doing real well. But I see Dr. Katani regularly, and that's about all I have to say.
Thank you very much for sharing your experience, and then you have been seizure-free, and you're willing to give motivational speech to everyone who suffered from seizure, that you could do it, and you're still doing great. Thank you very much. Anybody else want to say anything? Well, thank you for coming again in this Sunday, and thank you to all of you, not to repeat myself, but this was great, and